Okay, so we're live now. So if my audio and video inputs are good, please give me a thumbs up. Please give me a thumbs up if my audio and video inputs are good. Okay, let's begin then. So good evening everyone. My name is Dr. Daivik Shetty. I'm your orthopedic and PMR subject matter expert at Manipal Meddays, and today's session is the INICET Prepathon, and we'll be focusing mainly on physical medicine and rehabilitation, also a little bit about whatever high yield orthopedic topics we've not studied. So the main idea of having this INICET Prepathon is to make you revise much smarter. When the INICET comes closer, we want you to study these high yield topics which will yield more marks in the exam, and that will get you a better rank. So let's begin this session. So I have a few things that I want to tell you before we go into the questions and the topics. The first thing is, what will I be covering in this session? Good evening, Dr. Vidya. So first thing is what we'll be covering in this session. So in this session, mainly the focus will be on physical medicine and rehabilitation. But I understand that it is a new topic. It is a topic that has not been charted before. And that is why if I only talk about physical medicine and rehabilitation and give you all these new facts altogether, you are bound to lose yourself in the conversation. You're bound to not take interest in it, and that's why what I've done is not only have I included PMR questions, but also I've sandwiched them with a few orthopedic questions so that I can keep you engaged in this session. So what we'll do is we'll discuss both physical medicine and rehabilitation high yield topics, and along with that we'll discuss few orthopedic questions as well. Good evening, Dr. Abhirami. Good evening, Dr. Fatima. Welcome to the session. And in the last part of the session, like I've done in the previous session, I'll try to guess a few questions that might end up coming in your INICET exams. And this is not just a pure guess. This guess is mainly to do with the high yield topics and what is presently trending. Based on that, I've tried to make a segment called as Exam Leaks. Good evening, Nandana. So the first question you might ask me, the main thing I have to address is, why are we talking about physical medicine and rehabilitation mainly when no other platform is dealing with this subject called as physical medicine and rehabilitation? See, there's two reasons for that. One is NMC, one more is INICET. The reason is that this was a circular that was given out last year, mainly talking about the subjects that are relevant in terms of NMC, and the main subjects they've included also has physical medicine and rehabilitation in it. This is also mentioned. Now, giving the track record of INICET, it is you bound to ask certain bouncer questions, and NMC is unpredictable as it is. So based on this, it is better if we can cover PMR to whatever extent we know, so that we are well prepared for the INICET exam. And that is why we are conducting today's session, okay, to deal with the subject called as physical medicine and rehabilitation. And you will realize that this subject is not different from any other. It is just a culmination of medicine and orthopedics, and it's mainly dealing with the rehabilitation part, okay. So that is physical medicine. So these are all the high yield topics of physical medicine and rehabilitation. So look at all of these topics. You will see that most of them are covered either in orthopedics or in medicine, and this is just an extension of that. Disability, or be it stroke rehabilitation, all of this is covered in medicine. Orthosis and prosthesis, MSK disorders, then localizing spinal injuries, lesions, all of them are covered in orthopedics. So this is just a combination of orthopedics and medicine, and few other detailed things which I will tell you about. So few things are there which are high yield topics in INICET. So let's cover all of them. Let's cover PMR and let's cover orthopedics together in this session. Okay, so I'll need you to help me with all the questions. So we'll try to solve these questions together and then try to answer them. And the model I've told you, PMR, and in between them I have sandwiched certain orthopedic questions to keep you engaged. So let's start PMR chapter wise. The first chapter we'll be covering is Introduction and Disability. Good evening, Nandana, Shabir, Manisa, Smita, Soumya, all of you, good evening. Welcome to this session. So the first session in PMR that we'll be covering is Introduction and Disability. So first question here to all of you, try to answer this. Who is the father of physical medicine and rehabilitation? Your options are Nicholas Andre, Robert Jones, Frank H. Cruzen, and Hugh Owen Thomas. Now I've prepared this question in such a way that you will be able to answer it even if you don't know anything about PMR, because all four of these options are father of one field or the other. So if you can rule out three of them, you'll be able to answer who is the father of physical medicine and rehabilitation. Anyone who can try attempting this question? So if you even know one of these fathers, you can let me know in the comment section. So anything will help to try and solve this question. Anyone knows any of this answers? Good evening, Dr. Minakshi. Good evening, Jamula. Shabir says it's C, Frank H. Cruzen. Anyone else would like to take a guess? This is basically a guess because I know you've not studied much about physical medicine and rehabilitation. But what I'm telling you is try to rule out the other options. If you know what they are fathers of, then you can rule out the other options. Shabir is saying it's C, Frank H. Cruzen. Anyone else wants to try? Anyone else who knows what the other options are relevant for? That is also a good information for me to have. Vineet sir says it's B. Okay, so this is the first question, and mainly I want to talk about the other options before we go into the answer which Shabir has rightfully answered. Does Frank H. Cruzen. See, Nicholas Andre is the father of orthopedics. He was a pediatrician who gave this book called as Orthopedia, which was a self-help book, and because of that he was honored with this title of father of orthopedics, and that is why the name orthopedics came in. So he is Nicholas Andre, is a pediatrician who was given the title of father of orthopedics. But then they wanted an actual orthopedician to be a father, a pioneer in the field, and that is why they made Robert Jones the father of modern orthopedics, and Hugh Owen Thomas is the father of British orthopedics. He's the father of British orthopedics. So if they ask you who is the father of physical medicine and rehabilitation, the answer will be Frank H. Cruzen. But there is a catch here, and yes, Dr. Minakshi, you're right. Dr. Rusk also has a contribution. So remember, physical medicine, PMR, stands for two components. One is physical medicine, another is rehabilitation. So if they ask you who is the father of physical medicine, then the answer is Dr. Frank H. Cruzen, because he was one of the first physiatrists. We call PMR physicians as physiatrists. So he was the first physiatrist, so he is the father of physical medicine. But rehab medicine was started by a surgeon who was in the war. He took care of all of these veterans who were injured. So he introduced this concept of rehabilitation medicine. So if they ask you specifically father of rehab medicine, then the answer is Dr. Howard A. Rusk. If they ask you father of physical medicine, it is Dr. Frank H. Cruzen. But if they ask you PMR father, then the whole thing will again be Dr. Frank H. Cruzen. So Dr. Minakshi was right. Dr. Rusk is also one of the pioneer members who is the father of rehab medicine. Okay. Now in disability chapter, the only thing you need to know is how do we define disability, because there is a big difference between how PMR physicians describe disability and how orthopedicians do so. For us, if there is a fracture, we'll call that a disability, and once we've fixed it, we won't call it a disability again. But there is still a disability there, because the patient even after a surgery cannot do a certain things, is restricted, he'll still have some pain physically and environmentally, and that is why disability has another meaning, another definition, which is properly defined by this WHO model, that is the ICF model, that is International Classification of Functioning, Disability and Health, which says that health is multicentric. It has a lot of parameters into it. It reflects biopsychosocial model, which is based on disability and its dynamic interaction with conceptual factors and health conditions. It also takes into matter what is the activity and participation of the patient. Now, after a fracture is healed, patient will not be very active in the society. He'll still need some time, and that is why he still has some amount of disability, which a PMR physician mainly treats. Good evening, Dr. Sindhu. So now let's get back to ortho. Now that we've discussed two chapters, let's get back to ortho again. Here is a question for you. A 28-year-old male patient sustains a pelvis fracture in a road traffic accident and he is in hypovolumic shock. What is the immediate line of management that is to be followed? Is it to immediately fix it in the operation theater? Is it to use an external fixator? Is it to do a massive blood transfusion, or is it to go for an angioembolization? What do you think is the treatment here? I'll wait for the answers. So mainly they're asking you, how will you take care of a hemodynamically unstable kind of pelvic fracture? Anyone would like to try answering this? No answers? Okay, Stardust says it's C. Jamula says it's D, angioembolization. Anyone else would like to try? See, what is the protocol that we follow whenever we have a polytrauma patient coming like this with hypovolemic shock? Okay, Carol Desai says it is C, massive blood transfusion. So what protocol do we follow whenever we have any such injuries, polytraumas that come into us? What is that one protocol we follow before we take any patient into surgery? ABCD, correct. ABCDE is part of what protocol? Yes, Stardust, you're right. It is ABCDE, which is a primary survey of what kind of protocol? Shabir says it's C again. Balanced resuscitation. Okay, have you heard of advanced trauma life support? So it is the ATLS protocol that we'll follow in this question. So ATLS protocol, like he said, has it has A, B, C, D and E, where A stands for airway, B stands for breathing. Yes, Shabir, you're right. It's the ATLS protocol. C stands for circulation. So in this, the only thing that they've mentioned which resembles circulation is massive blood transfusion. So that becomes the answer in this question. So all of you are right. It is massive blood transfusion. See, angioembolization, you external fixator, operation, then doing immediate fixation. All of this requires the patient to go to an OT, and that will be too late by then. So the immediate thing you will do is a massive blood transfusion. So that was one way of answering it. Now look at another question here. This was an INICET 2023 question where again, see, the words are almost the same. A 28-year-old male patient, pelvis fracture, road traffic accident, hypovolemic shock. What is the immediate line of management? But the options have changed now. One option is immediate fixation in the OT. One more is use of external fixator. Third one is massive blood transfusion. And fourth one is tie the pelvis tightly with a bed sheet. You have a different option D. Now, Shabir, Stardust, Carol, Jamula, will you change your option or will the answer still be the same? Shabir says he'll change his answer to D. Starry Sky also says the answer will change to D. Okay, yeah, this is a concept you have to understand. That see, in pelvis fracture, the reason they're going for hypovolemic shock, the reason so much blood loss is happening is because mainly it is the venous plexus that has gotten damaged, and that is why there is severe bleeding. So to stop that venous plexus from bleeding, you have to do some kind of tamponade. So whenever there is a bleeding superficially, we keep a compression. But in pelvis fractures, we cannot keep a compression, man. So what we have to do is we have to create some kind of tamponade so that that venous plexus bleeding can reduce. And that you can do either using a pelvic binder or by tying the pelvis tightly with a bedsheet. And later, you can send for cross-matching, you can do a massive blood transfusion. But the immediate step is to stop blood transfusion. So either to stop the blood that is being lost. Okay, so even though ATLS protocol will be followed here, but because it's a pelvis fracture, because there is severe venous plexus bleeding, one thing we have to do before ATLS protocol is to tie a pelvis tightly with a bedsheet or do some kind of tamponade effect to stop this bleeding. So understand this, that in pelvis fractures, mainly bleeding is occurring because of thin-walled venous plexus that are rupturing and leading to a lot of loss, and also because of bleeding cancellous vessels. Rarely is it because of arterial bleeding. It's mainly because of venous bleeding and cancellous bone bleeding. So to stop this, you have to create some kind of tamponade effect. You have to do some kind of tamponade effect, and that is done by tying the bedsheet tightly. Is this clear? So this is an anatomy that shows you how the venous plexus get damaged, and there is damage to also corona mortis, which is the crown of death area there. So this is a protocol that you have to follow. Please remember that although we follow ATLS, to stop bleeding at the pelvic side, first thing is to do a pelvic packing and apply a binder. And then we can do massive blood transfusion and fluid replacement. So if they don't have pelvic packing in the option, then your answer becomes either fluid replacement or massive blood transfusion. But if pelvic packing is there in the option, then always choose that. Okay, is that clear? So this you can see here, this is a pelvic binder, and this is the external fixator that you use. In cases of open book pelvic injuries, you can close them by using an external fixator. Okay, so these are a few things that are used in treatment. So the answer, like you all said, is D. Correct, you are all right, it is D. Now coming to another recall question, and this was a bouncer when it was asked. So they are told that there is a femoral shaft fracture and your consultant asks you to provide tibial skeletal traction. Which of the following instruments will you ask the OT to arrange in order to do a tibial skeletal traction? Options are, all the instruments that are kept are Thomas splint, K-wire, Steinman, pin, Denham pin, Bowler stirrup and Bowler-Braun splinter frame, and you have these options here. Okay, so this was a bouncer when it had come up because it was not included in most of the sessions. But if you attended internship well, if you've seen ortho postings, you will know what the answer is. So can all of you tell me what the answer is? Starry Sky says it's B. So he means B in the sense there is 3, 5 and 6. Steinman pin, Bowler stirrup and Bowler-Braun sprint. Okay. So even Shabir agrees with it, even Carol agrees with it. So all of them are saying it is B. So let's understand. So let me take you back to the clinics. Let me take you back to the OPD where someone is putting a tibial traction. Okay. Stardust says it's A, 3, 4, 1. Steinman pin, Dunham pin and Thomas splint. Okay, so Stardust. So let's go back to our hospitals. Let's go back to hospitals and let's see how we do this skeletal traction fixation. So first we take the patient into the OT, and in the OT what we do is look at this with image, look at the animation or the video that is placed here. So you can see here how first we are applying a pin into the proximal tibia. We're drilling a pin into the proximal tibia. We do all the marking. We see to it that the neurovascular area is kept away, and then we put this pin. So please look at the pin here. What pin do we use in cases of external fixator application? So normally this is the pin that we use. So let me tell you both these pins. So this pin here is the Steinman pin, and this pin here is the Denham pin. What is the difference between both of them? In Denham pin, you will have these threadings in the middle. So these threadings will be there in the middle. So they are the Denham pin. So normally we'll just use a Steinman pin, which will give us good purchase into the bone. But in osteoporotic bones, or whenever we're doing a calcaneum traction fixation, so in cases of osteoporotic bone, or sometimes whenever there is tibia fracture, we might put a calcaneal traction. Calcaneal skeletal traction. In those cases, we'll use a Denham pin. What is the advantage of Denham pin? Because these threadings are present, these threadings will hold the bone tightly in an osteoporotic fracture and will not allow for implant failure. So that is when we use Denham pins. Normally, we always use a Steinman pin. So step 1 was to use a Steinman pin. So this is what has happened here. The surgeon has put a pin into the bone. Now you have to hold that pin with some frame. So what is the frame that you will use to hold the pin? That is your Bowler stirrup. So this is a Bowler stirrup. You would have seen this in your clinics, in the orthopedic wards and OPDs. You would have seen a Bowler stirrup being used. Now this Bowler stirrup and the leg in itself has to be placed in something. We have to keep this leg in immobilization in some kind of device, and that device is a Bowler-Braun splint. So you will keep it in a Bowler-Braun splint, and the advantage of this Bowler-Braun splint is that it has these 3 pulleys. You can see these 3 pulleys. So you will get different angle of placing the traction. Now because it is a femur fracture, we will place the pulleys through pulley B. This pulley, we will use this pulley to put a weight, and through this we are giving a traction. So what are the things that we need to use? We have to use a Steinman pin, not a Dunham pin, a Steinman pin. We have to use a Bowler stirrup. We have to use a Bowler-Braun splint, and we have to use pulleys and weights. So the options that we have here are Steinman pin, Bowler stirrup and Bowler-Braun splint or frame. Okay, so this was the answer. Most of you got it right. Okay, it is 3, 5, 6. B is the answer. Now a little bit you need to know about Bowler-Braun splint, that it has 3 pulleys which are marked here as A, B and C. So the C pulley is mainly helpful for foot drop. If a patient has foot drop, it can hold it in place like it is holding here. It will hold the foot in place. B is mainly used for femoral fractures, like in our case, when there was a femoral fracture, because this is in line with the femur, we can use B pulley. This A pulley is mainly used in tibia fractures or calcaneum fractures where you want a straight traction. So in those cases, we'll use pulley A. So this is a Bowler-Braun splint, and these are its 3 pulleys. Okay, the advantage is ease of immobilization. You can keep it here, and also varied angles of pulleys, which will give you different kinds of traction. Okay, so this was a question that was already asked. So they can ask a question similar to this using another implant. So look at this question here. This is talking about an implant that is called as Ilizarov's apparatus, and I'm pretty sure all of you have seen an Ilizarov apparatus in your hospital, or at least when you studied in theory for it. So your resident is now wanting to do an Ilizarov apparatus application. He asks you to arrange these instruments that he requires for Ilizarov apparatus. Which instruments will you select? Your options are Steinman pin, Schanz pin, frame, olive wire, pin clamps and bolts, Bowler stirrup and Thomas splint. So these are all your instruments. Which instruments are required to do a Ilizarov's apparatus? Now, even if you know one thing that is definitely required in Ilizarov, please put it up in the comment box. Let's see how much of Ilizarov have you learned. Let's try to recollect all of that. What are required for an Ilizarov fixator? I'm pretty sure you've all seen an Ilizarov fixator, these circular devices which are holding a fracture in place, mainly in open fractures or in limb lengthening procedures or bone transport. We use them. That is an Ilizarov fixator. So frame, okay, correct. Frame is required in Ilizarov fixator. So Shabir is right. Frame is one of the things that is definitely required. Frame is those circular things laying outside. Pin clamps, correct. Pin clamps and bolts are definitely required. Starry sky is right here. So two things required. Anything else? See, to hold the bone, pin clamps are not enough. Frame is not enough. So what is the thing that will hold the bone? Which pin do you think holds the bone in a case of Ilizarov fixator? Anyone knows the answer to this? Shan spin. Shabir says it's Shan spin. Correct. We'll use a Shan spin. Shabir, or Shan spin here. You're right, Dr. Starry Sky. We will use Shan spin here, not Steinman pin. So that was one of the tricks that I want here. One more thing. Anything else that we would use? See, I'm pretty sure Thomas splint is not something that we'll use. Steinman pin also is not used. Shan spin, pin clamp and frame, correct. Dr. Abhirami is also absolutely right. Any other thing that you think would be used? See, in Ilizarov, the main thing is we have to tension the bone, not just keep it in frame. The reason Ilizarov is different from external fixator is that the bone, even though it is kept within a ring, even though there is some kind of pins put in, you have to give it some tensioning, and that tensioning is given using a wire called as the olive wire. Shabir is absolutely right. It is the olive wire that we use. So this is an Ilizarov fixator. I'm pretty sure all of you seen an Ilizarov fixator. Now let's try to break down its parts. See, the first and most obvious thing that we all answered is these things here that I'm marking in green. These things here, these are the frames. We use frames, correct? So we use frames to keep them tight. Then look at this. These pins here, look at this pins here, these pins here, or these pins here. These are your Shan spin. This is a Shan spin, not a Steinman pin. We use a Shan spin in cases of Ilizarov fixator. Now the third thing I want you to notice, please appreciate this, which I'll mark in red, is can you see here that few of these wires have these beadings. They have these beadings here. Even here you can see there is this beaded wire. So these beaded wires are not Shan spins. They are in fact olive wires. They are olive wires because of that circly thing which maybe resembles an olive. So they are olive wires and they are used to tension the bone. And then you have all of these clamps that are there. Pins and clamps are kept in place. So we have pins and clamps and other devices. So many other secondary devices also come in, but primarily these are the four things that keep it in place. So the answer here is 2, 3, 4 and 5. That is Shan spin, frame, olive wire and pin clamps and bolts. Okay. So this is the answer. Please remember this. You have to study a little bit about Ilizarov fixator and its principles because it is a high yield topic in your INICET exam. So that was about orthopedics. Now let's again come back to PMR. Let's discuss another topic in PMR, that is cerebrovascular accidents. And in cerebrovascular accidents, first thing you need to know is a concept of what is spasticity and what is rigidity. So look at this question here. A 65-year-old male presents with tremors and stiffness in his limbs. On examination, there is rigidity noted with on and off resistance in the upper extremities with jerky quality, particularly during passive movement, resembling a ratchety sensation. Which of the following is the likely diagnosis? And your options are Parkinson's disease, Huntington's disease, ALS and multiple sclerosis. Anyone would like to take a guess? See, mainly the concept I'm trying to test here is about, do you know about different types of rigidity and spasticity? So here they've mentioned rigidity to be on and off resistance with upper extremities being jerky quality. Correct. Shabir says it's A. So before you go into the answer particularly, let's first look at what type of rigidity. Shabir, Stardust also says it's A. Shabir, what type of rigidity do you think is mentioned in this question? Correct. Parkinsonism. Everyone's telling it's Parkinsonism. But what type of rigidity is mentioned here? What type of rigidity is mentioned in correct? The answer is Parkinsonism. So all of you are right. Starry Sky, Stardust, Shabir, all of you are right. But can you also elaborate as to what type of rigidity is being described in the options here? No answer. Okay. So let me tell that to you. See, this is something you have to know about when it comes to PMR. Mainly, difference between spasticity and rigidity. Both are types of hypertonicity that is seen, but there are two types of rigidity. Yeah, correct. Cogwheel rigidity. Correct. Shabir, you are right. Not lead pipe rigidity. See, I'll tell you the difference between both of them. So in lead pipe rigidity, there is same type of tonicity felt throughout the range of motion. That is why it feels like bending a lead pipe. There is throughout resistance, same type of resistance throughout. So that is lead pipe rigidity. Cogwheel rigidity is when you have intermittent increased tones. So there is intermittent types of increased tones in a way how a cogwheel moves. Okay, so that is the difference. And cogwheel rigidity is mainly seen in EPS syndromes like Parkinsonism. Okay, so the answer is the cogwheel rigidity that I was looking for. And you know, in spasticity, you have this clasp knife effect where there is some kind of resistance which then eases out. Okay, so that is the difference between spasticity and rigidity, and difference between cogwheel and lead pipe rigidity. In Parkinsonism, what do we see? We see cogwheel rigidity. Okay, is that clear? Then few MCQs from PMR side about spasticity you need to know. These are one-liners. See, most commonly used or first line drug that we use in spasticity is baclofen. But if you have to focus on a target muscle, what we do nowadays is we give botulinum toxin focal injections. And also there is a concept of using an intrathecal baclofen, but remember that we never use intrathecal baclofen as first line drug. We'll only use it in cases of severe spasticity where oral medications have failed us. Okay, remember these three MCQs about intrathecal baclofen being the first line drug for spasticity, and botulinum toxin being used as a focal injection in case of targeting a particular muscle. So the answer is Parkinsonism. All of you are correct again. Now let's come into another question. This is again a question of PMR where they're talking about first intentional movement to recover after stroke according to the Twitchell theory, which is a theory that is commonly followed. That is Twitchell's theory of recovery in stroke. So in that, which is the first intentional movement to recover? A patient with a case of stroke will have upper limb and lower limb deficits. He'll have weakness. So which do you think resolves first? Hip flexion, shoulder extension, shoulder flexion, and elbow flexion? Anyone would like to guess, or anyone who's seen through observation that which one usually resolves first? I know these concepts have not been covered, so I'll just a guess would be good enough. I'll explain to you this whole theory of Twitchell's recovery. Anyone would like to take a guess at this? Okay, Dr. Jain says it's C, shoulder flexion. Starry Sky says it's D, elbow flexion. Stardust says it's D again, elbow flexion. Okay, kudos to trying, all of you. So let's discuss what this Twitchell's theory actually talks about. So this Twitchell's theory is mainly talking about how recovery occurs in upper limb and lower limb in cases of stroke. So recovery usually occurs in the shoulder first. In the shoulder, and the first movement, usually all recoveries first are flexion. So the first intentional movement that will recover is shoulder flexion, and then elbow flexion, and then wrist flexion, and all of that. And once the flexion synergy is occurred, then you will have this extension synergy that will occur. Then you will have, once the flexion synergy happens, then you will have this extension synergy that happens in the upper limb. And then the first movement in the lower limb that you will get is hip flexion. And then again all the flexions and then extension. So this is what the recovery happens. So the first intentional movement to recover will be shoulder flexion, usually between 6 to 33 days. And then you will have flexion synergy, that is flexion of elbow, flexion of wrist, all of that. And then extensor synergy, and then the lower extremity. If they ask you another question saying which lower limb movement first recovers, then the answer is hip flexion. But tendon reflexes will again remain the same. And remember that once the complete recovery occurs, it is usually leg recovery which is earlier and more complete than arm recovery. Okay, so this is some things you need to remember from PMR side. So the first thing is shoulder flexion that recovers in stroke. Is that clear? Okay, so this is a concept that I don't think has been covered much, so I just want you to take note of all of them, maybe asked in your INICET exams. Another thing is important scores in stroke rehabilitation. Please remember at least the ones that I have marked, they are very important. So how will you evaluate different criteria of stroke? First thing is how to evaluate the prognosis, and that is done using two criteria. One is National Institute of Health stroke scale, and another is functional independent measurement for ADL. This is mainly for ADL, okay, activities of daily living. Then for hand function, you have the Wolf scale. For disability evaluation, modified Rankin scale, ambulation is by Hoffer and Bullock score, and spasticity hand function is by Fugel-Meyer scoring. So these two are important. So if you can't remember any of them, at least remember these two. Okay, these are newer concepts that you have to remember. Now coming back to orthopedics again, I had a lot of requests in the group to discuss about implants, mainly screws and nails and all of them. So I've included this question here where you have 4 implants marked as A, B, C and D. And then we've given a description in the side which mentions it as dynamic hip screw, femoral intermedullary nail, tense nail and tibial intermedullary nail. Now you have to match these implants for their description. Take your time, this will take a little time. So please mark these. Try to find out which is a dynamic hip screw, which is a femoral intramedullary nail, which is a tense nail and which is a tibial intramedullary nail. Even if you know one of these answers, you can tell me in the comment box. If you know what A is, what B is, or what C is or D is, you can tell me. Dr. Jain says it's A. Shabbir also says it's A. Debra Sarkar says it's C. Okay, Stardust believes that B stands for 2. B stands for 2, meaning this, he says, is a femoral nail. And C stands for 1. This, he says, is a dynamic hip screw. Okay. And any other answers? See, even if you know one option, it's okay. Even if you know what C is or D is, you can just put it in the comments. Okay, let me ask you like this. Do you think this is a femoral nail or a tibial nail? A, the one A that is shown here. Do you think this is a femoral or a tibial nail? And also the reason, if you can give me. Okay, Stardust says A is tibial nail. And anyone else with a different opinion? Or Stardust, why do you think, if it is, if you can help me with the answer, can you tell me why do you think this is strongly tibial nail? Femoral nail, because it is bent. Okay, Shabir says it's femoral nail because of this bend, because there's one bend that he's seeing. He says that this is a femoral nail. Anyone else would like to say? Dr. Jain says femoral nail because it is bent. Okay, fine. Alright then, so let's try to understand this, and let's try to understand where you're all going wrong. I actually couldn't tell much difference between A and B, sir, as both have bends. Okay, no, I'll tell you A has bends. A has bend. So why do you think that bend is in a nail, and where do we use it? See, B, this is a curved nail, not a bent nail. Slight curve is there. So tibial nail, always, this nail, you'll always see there is a bend. So I'll tell you what the answer is. I've almost given it away. So please remember, look at this. See, I'll show you this video here. Look at this video of how a tibial nail is put inside. So this is how we do it in the OT. How do we put a tibial nail inside? See here, now they've reamed, they've put a guide wire, and through this, now they're going to pass a nail. So now see here. So this is a nail that is being put inside. Can you see that to put that nail inside, because it is in this proximal tibial junction, to put that nail inside, they have to compensate that curve. And that curve is compensated with that help of a bend. This bend in the nail, which is called as Herzog bend. It is called as Herzog bend. This is a feature of a tibial nail. Not a femoral nail, Stardust, not a femoral nail, Shabir. This is a tibial nail. That bend, what is there, what you see, is usually in tibial nails, because as you see in the fixation, it helps us fix it better. Because of that pathway that it takes for the nail to go inside, we need to have that bend. Okay, that is why tibial nail will always have that bend in it. Femoral nails don't need a bend. It is, see here how a femoral nail is put. This is a proximal femoral short nail that is being put inside a fairly straight area. Because there is some amount of curve in the femur, this nail will have a curve, not a bend. It will have some amount of curve which you might not be able to see in a 2D image, but the bend you will be able to see in a tibial nail. So did you understand the difference here of how to answer which nail is which? In tibial nail, you will always have the Herzog bend. In a femoral nail, it will be fairly straight. Okay, so this is the difference between a tibial and femoral nail. The full name to that is intramedullary interlocking nails. Okay, because we put locking screws above and below, we call them as intramedullary interlocking nails. Fine. So those were two of them. We've solved both of them. So this is a PFN that is being used. This is a PFN. Okay. The next one is DHS, which I think Stardust mentioned it. C is DHS, that is dynamic hip screw. See, what happens in dynamic hip screw is that there are two components. One is this screw, which, if you want to know the name, is Richard screw. This is called as Richard screw, and this is a side barrel. This is a side barrel, and these two are different implants which are put together. Now what you do is, once you fix the screw and then put a barrel, what happens is this screw slides in the barrel. Little bit of sliding is there. And why is the sliding there? Because at the fracture side, because of the sliding, there will be compression at the fracture side, and when there is compression, there is good healing. Remember, whenever there is compression, whenever we put a plate also, we try to compress the fracture and then put a plate. Similarly here also, once you put that screw and that barrel plate, because of some amount of sliding between that screw and the plate, it will result in good healing, and that is the reason this is called as a dynamic hip screw or a sliding hip screw. Dynamic because there is movement. Do you understand the difference between static and dynamic? No, static is when there is no movement. This is a dynamic hip screw because of this feature. Okay, it is mainly used in neck of femur and some kinds of IT fractures. So mainly used in proximal femur fractures. The name is dynamic hip screw. Stardust was exactly right. Okay, what is this last one? Can someone tell me what is this nail? You can see two of these thin nails which are bent a little, which are put inside. What are these nails called as? Anyone would like to guess? Tense, correct. Stardust is exactly right here. It is a tense nail. It is a titanium elastic nail system. So why do we use this? So in pediatric fractures, we cannot put this big nails. We cannot do nail fixation, or even in forearm fractures, we cannot do nail fixation. But what we can do is we can use these elastic titanium nails or thin nails, which can see, you can see how they are being inserted. Look at that image here. Look at the animation here. Can you see how they're making a small hole and then stacking one tense nail inside? Now this tense nail is going to go and sit inside, and because it can be manipulated a little, you can stack both nails in this cross fashion. So can you see here, one nail has been put inside, now they're putting another tense nail inside. So this way you are getting fixation in pediatric fractures, or even in forearm fractures you're getting a fixation. So this is called as a titanium elastic nail system, or in short it is called as TENS. Dr. Jain, you're also absolutely right. It is a TENS nail. So the answer there was, this is a TENS nail, this is a dynamic hip screw, and then you know the difference between tibial and femoral nail. Okay, now let's talk about screws. Someone in the group also asked me to describe about screws. So let's understand this concept of which screws are what. Lot of confusion among this topic. So please look at this. I have 4 screws here. All 4 might look similar, but they're different. Okay, all 4 are different types of screws. Can you describe them? A, B, C and D, and the options are locking screw, Herbert screw, cortical screw and cancellous screw. See, again, even if you know one of them, you can, if you're confident about what A is, you can tell that to me and we'll go forward with that also. I need some information from you guys. If any previous concept is not clear and you want me to revisit, I will go back gladly. Now, if you know the answer to this or any one implant. Okay, Shabir says A is cortical, B is cancellous. Anyone agrees with them? Anyone has a different opinion? Someone likes to take a crack at what C and D is. C, Dr. Jain says, is Herbert screw. Okay. What is D? Let me focus on D here for some time. Anyone would like to solve this one thing? What is D? Or what is A and B? If you agree with Shabir or you have a different opinion, please let me know. So Stardust believes C is locking. Dr. Jain believes D is locking. Okay. So let's understand this. So to understand screws, basically you need to know a little bit about screws and about hardware. I won't go into detail, but please remember that in a screw there is head. This part is head. And these are the threads that are there in the shaft. These are the threads. Now let me zoom in here. So between these threads, between two of these threads, the distance that is there, that we refer to as pitch. We call that as pitch. between two threads, no, whatever is there, we call that as pitch. Okay, starters believes D is cancellous screw. Okay, starters, let's see the answer now. Okay, so see, between two threads, whatever distance is there, that is called as pitch. Okay, covered head is, what do you mean by covered head, Jane? I think I'll tell this explanation, and even if you didn't understand, then maybe we'll get back to your question. So see, pitch is this distance. Is this clear? And then this is the head. All right. So now, so again, I'll show you, this is a pitch in a thread. So always, whenever any screw is given to you, only thing I want you to notice is the head and the pitch. Only two things. Okay. So let me show you here. Two screws I've kept in front of you. First, let me focus on this screw here. This screw, can you see the pitch between these two threads? Between these two threads, can you see there is a lot of distance? There is increased pitch here. Whereas here, can you see there is very short pitches? So there is decreased pitch here. This is much more compact. Why is this different? Because see, this is a cancellous screw. Sorry. This is a cancellous screw and this is a cortical screw. And why do we have this differences? Cancellous bone is spongy bone. It has a lot of porous structures in it, and it is not easy to fix any implant to a cancellous bone because it might come off. So whenever we're putting a screw in a cancellous bone, we have to put a screw in which there is a large chunk in between which can hold a lot of bone in between them. That is why the pitch is large. But in cortical bone, the problem is different. In cortical bone, the bone is so compact that you cannot put a screw that can easily pierce that compact bone, and that is why we need a structure also that is supposed to be hard, and that is why pitch is very less, but we have a lot of threads in a cortical bone because it should be easily piercing a compact bone. That is why that is the difference between cortical and cancellous bone. The pitch is less in cortical bone, it is more in cancellous bone. But look at the head. Look at the head in both cancellous and cortical bone. The head has no threads in them. It does not have any thread in them. So no threads. There are no threads. Now let's look at another implant here. See here, look at this implant here. Can you see that the head also has threads in them? This looks like a cortical screw, but the head also has threads in them. Why is this threads there? Because whenever we are putting a screw in a plate, we want good fixation. We want the screw to sit tightly, not just with the bone, but also with the plate as well. And that is why it needs to lock with the plate. And that is why we use this locking screws. So look at this image here. Can you see how even the head is getting locked with the plate? And this is called as locking screw. This is called as locking screw. Now let's talk about another implant. This implant here. Can you see here? Thread also has head, the head also has threads in them. But can you see that the pitch between these threads and these threads are different? So there is a differential pitch. Here the pitch is same. So why is this differential pitch there? Because when we want to fix these small bones like a scaphoid bone fixation, we do it percutaneously. We don't reduce the bone and then fix it. With the screw itself, we want the fixation to happen, the reduction to happen. And that is why if we put this Herbert screw, this is called as Herbert screw. If we put this Herbert screw into a scaphoid, you will be able to see that because of the differential pitch, there will be reduction of the bone and also the screw will go inside with the reduction. That is why Herbert screw is being used. So this is a Herbert screw. If you can see here, this is a Herbert screw. So did you understand the difference here between all four of them? Did you understand this? So is it clear now? So what the options were? Okay. So do you want me to go back again and so what is A? Can someone tell me now what is A? What do you think is A, B, C, D? Can you all tell me now? Which one is which? Did you guys understand the difference? Any doubts here? Yes, so A is cortical, B is cancellous. So C is Herbert screw or C is locking screw? Yes, B is cancellous, correct. Starters, you're right. C is Herbert screw, correct. And D will be locking screw. Okay, so is this understood? So this was about screws. So now Not a question, something just rhetorical. What do people forget during their exam? So you might think it's ID card, admit card, or exam location. But what I've noticed mainly when it comes to these INICET exams is the main thing missing when someone goes to the exam is common sense. So please remember that INICET exam is more about your logic and your sense. So please have a good sleep schedule when an exam comes closer to, when the exam dates come closer, have a good sleep schedule, because the most important thing is not this last minute revision. Don't try to study all throughout the night, okay, because common sense is more important here when it comes to the INICET exams. All right, so this is something that I just wanted to mention. Now let's go back to PMR. Let's go back to another important topic in PMR, that is cerebral palsy, which might be asked as a question to you. So I have a video here which I'll show you shortly, and you have to guess the gait that the patient is doing in this. Okay, which gait is it? The options are Trendelenburg gait, couched gait, scissoring gait, and high stepping gait. So please observe the video. Okay, the video is coming now. Did you guys see the video? What do you think is this gait? Pranav says it's C, scissoring gait. Shabir also says it's C, scissoring gait. Debrad says it's C. Okay, scissoring gait, yeah, right. So the answer here is scissoring gait. Where is it commonly seen? Which disease? Cerebral palsy, because it's the topic that we're discussing. Cerebral palsy is where you see scissoring gait. We also see crouched gait here. So why do we see different kinds of gait in cerebral palsy? So please understand what the disorder is. It is a non-progressive neuromuscular disorder of cerebellar origin. Here the disease can be different types. It can be spastic, ethetoid, or ataxic type. So most common one is spastic, where you have this upper motor neuron disorder, where there will be a lesion in the upper motor neuron, because of which this GABA will not be secreted, which is mainly an inhibitory response. So when there is loss of inhibitory response, there will be overexcitation of the muscle. And when there is overexcitation of the muscles will be in a state of hypertonia. Now imagine an adductor muscle hypertonia. Whenever a patient has adductor muscle hypertonia, he will walk in such a way that always the knee will start touching the opposite thigh. So he'll have this kind of crossing over movement, which is called as scissoring gait. So whenever there is adductor spasm, like you saw in that child, he has severe adductor spasm, because of which he is having scissoring gait. Now if the muscle affected is Achilles tendon, if there is overexcitation of Achilles tendon, then the gait will change. Even in cerebral palsy patient, they'll start having toe walking type of gait. Okay, so this was about spastic. Another type is ethetoid, where basal ganglia is getting affected. Here basal ganglia is getting affected, because of which movements are getting affected, and you will have two types of movements. One is chorea, one is dystonia. I won't go into the details of that because it's covered. So you'll have these two types of random involuntary movements, because basal ganglia is damaged. Voluntary activities are low, involuntary activities are more. Involuntary activities involve chorea and dystonia, which is a type 2 ethetoid type of cerebral palsy. Type 3 is ataxic, which mainly involves the cerebellum. Okay, so this is a gait that you commonly see in cases of diplegic type of patients with spastic cerebral palsy, that is a scissoring gait. Any other gait that you know in cerebral palsy patients? Is there only scissoring gait? Are there more gaits that are seen in patients of cerebral palsy? Hemiplegic gait. Okay, any other gaits? Okay, so let's discuss those. So see here, this is the gait where toe walking is seen. So common gait patterns are toe walking gait, which is when there is equinus, crouched knee gait, or also called as crouched tiger gait, where hip flexion, knee flexion, and ankle dorsiflexion is there. Jump knee gait, when there is hip flexion, knee flexion, and ankle plantar flexion. Scissoring gait, like the one that you saw, because of hip adductor spasm. And sometimes if only knee muscles are affected, stiff knee gait also will be seen. So these are all the gait patterns seen in patients of cerebral palsy. So the answer was scissoring gait. Okay. Now let's go back to orthopedics again. One important topic that I wanted to cover in orthopedics is spinal tuberculosis, a high yield concept here. So here the question is, which is the most common pattern of port spine involvement? And this was an INICET May 22 question. So the options are paradiscal, central, anterior, posterior. I'm pretty sure you have all heard of types of port spine involvement or types of port spine. Can you tell me the answer? Very simple question. Dr. Jain says it's paradiscal. Stardust says it's paradiscal. Anyone else would like to contribute? Fairly simple question. Which is the most common type of port spine? Anyone else? Okay, so you're right, paradiscal is the most common type. Now, the main thing I wanted to focus here is to understand the concept as to why we have different types of TB spine and why paradiscal is the most common. Debraj, you're right, it is paradiscal type. Shabir, also you're right, paradiscal type. So why, we have to understand the why as well. Why do we have paradiscal type? Why do we have central, anterior and posterior types? Why in TB spine there are different patterns, and to know that you need to know a little bit about the anatomy. So understand that vertebrae and discs come from sclerotomes, and usually this much part, that is one half of the vertebrae, the disc, and another half of the adjacent vertebrae, this much area arises from a single sclerotome, and every single sclerotome will have a same blood supply. So they'll have this common blood supply. So this is the blood supply to the vertebrae, and this is how it goes through hematological spread. Dr. Jain, you're right. Yeah, that is the concept I'm trying to explain here. So arterial blood supply, let's understand how hematological spread happens. So you see here the arterial supply is mainly towards the lower vertebrae, adjacent upper vertebrae and the disc. This is the arterial supply. Now let's look at the venous supply. How does veins go into the vertebrae? Can you see how these veins are going directly inwards? They're directly going into the center of the vertebral body. They're all going directly into the center of the vertebral body. So this is how venous plexus occur. Meenakshi sir, you are also right. It's single sclerotome. That is why arterial spread and paradiscal type is seen. But also let's understand why anterior and other types are seen. Central type is seen. Okay. So this is a venous spread directly into the bone. Now let's look at the muscle. So look at the ligaments. So ligaments usually are spread anteriorly and posteriorly. Anteriorly you have this here, the anterior longitudinal ligament, and posteriorly or posterior to the vertebrae you have the posterior longitudinal ligament. Now the spread in TB, we know that always extraskeletal TB, that is spine TB, is secondary. It occurs after either a primary TB in the lung, okay, or any other site. So through there, this TB bacilli is going to come into the spine and it is going to cause TB of the spine. So how can it enter? So it has three main or four routes through which a TB bacilli can enter into the vertebrae. The most common one, like Meenakshi sir, like Dr. Jain said, is through arterial spread. So we know how arteries are kept. They're like this, paradiscal involvement. So when a bacilli goes, it will cause damage to the paradiscal bone and the disc, and that is why whenever you see a paradiscal type of TB, you will see an involvement of lower part of the vertebrae, upper part of the adjacent vertebrae and the disc. All of this is eroded. So this is how a TB is seen whenever it is paradiscal type. But if the TB bacilli decides that it does not want to go from the artery, it wants to go from somewhere else, so what other options does it have? It can now go through veins as well. So when it goes through the veins, it will go into the center of the bone. I showed you how venous spread is. No, it goes into the center of the vertebrae and it will cause destruction in the center of a single vertebrae. So if you see a single vertebrae central destruction, then you know that this is a type of central TB or also a venous spread type of TB. Did you understand this? Now, the TB bacilli decides it does not want to go through the artery, it does not want to go through the vein, it wants to grow subligamentous. Now, which ligament is there? We have the anterior longitudinal ligament, which is spread across the anterior vertebrae of multiple vertebrae. So now, if this bacilli goes in this direction, it will cause multiple vertebrae anterior bone damage, and this is called as an anterior type of TB. Okay, so these are the three types, and rarely sometimes you will have this posterior involvement. So posterior element involvement will be very rare. That is posterior type of TB. So did you understand four types of TB here? So we have anterior lesion, which is by subligamentous spread, central by venous spread, paradiscal by arterial spread or hematogenous spread, and posterior, which is very rare. Okay, most common, if they ask you, you know that hematogenous spread is most common. So this is the most common type. So that answers your question. So this is what I was trying to explain. Paradiscal is arterial spread. Central is venous spread. Single vertebrae is involved. There will be wedging of the area. Disc won't be involved because venous goes directly into the vertebrae. And also And also posterior and anterior type. Anterior is subperiosteal spread and posterior is spread through posterior element. So why is this important? Because through this clinically also you can interpret a lot of things. So if you get an MRI where you see that multiple vertebrae anteriorly are involved, then you know that this is a subligamentous spread. This is a subperiosteal spread of TB and not an arterial or venous type. So this is the difference between types of TB. Okay, I hope you remember this: anterior, central, paradiscal, posterior. Okay. So that was the answer. This was one of the questions asked in your INICET exams. Now let's go a little bit further into TB spine. Let's understand about the treatment. So read this question here. A 32-year-old man is diagnosed with a case of tuberculosis of spine. He has no neurological deficits. No, in central type only single vertebrae will be involved. Central type is venous type, no Stardust. So in central type, only one vertebrae wedge fracture you will see. No disc involvement. Maybe because of that there will be a collapse. The spine can go into kyphosis. But the vertebrae mainly involved will be just one vertebrae going into wedge compression. Similarly, in a case of paradiscal, both two vertebrae will undergo collapse and they might even fuse. So usually what you will see is two vertebrae would have fused after destruction. So that is seen in paradiscal. Okay. So wonder gap, Dr. Akshay, hello. Okay. So this question, let's come back to here. Tuberculosis of spine. A patient was diagnosed with tuberculosis of spine. He has no neurological deficits. Based on middle path regime. I hope you all know what is middle path regime given by Dr. Tulli. He was started on anti-tubercular medication with strict bed rest. The patient now will come back to you 1 month later taking ATT medication. He's been taking ATT medication regularly, but now he has got new onset neurological deficits. What is your next step? Is it to continue ATT medications? Is it to add second line drugs? Is it to do a decompression surgery, or you have to go for another biopsy? Do you have to go for another biopsy? Remember, previously biopsy was done. He was proven to be TB spine positive and then treatment was done. Okay, Shabir and Dr. Jain says it is C, decompression surgery. Okay, so Shabir says it's C. Dr. Jain also says, okay, Shabir and Dr. Jain, I want to know from you that when would you consider, so imagine this patient has no neurological deficits. What other indications would you consider the answer being decompression surgery? Stardust says it's A, continue ATT medications. Okay, we'll see what is the right answer later. But Shabir and Dr. Jain, I have this question for you. When would you consider, so this patient, imagine same patient comes with no neurological deficits, but he has something else. What something else will again compel you to go for surgery? What I'm asking you is indications of surgery in middle path regime. Anything else? Quada equina, correct Dr. Jain, quada equina, new onset deficits. Okay, anything else? Right, so Shabir and Dr. Jain, you are absolutely right when you told it is decompression surgery. Stardust, the reason A will not be the answer is because now patient has started developing new onset neurological deficits. See, this patient, the reason we gave him ATT and did not go for surgery was because he had no neurological deficits. Now, once he starts developing neurological deficits, then we have to go for decompression surgery. Okay, so this is the middle path regime given by Dr. Tulli, and the reason he gave them is because earlier in Western countries, whenever there was TB spine, always they went for surgery. In India, because we were a relatively poor country, we always went for ATT treatment, and there was complications because of only giving ATT treatment. So SM Tulli came up with this middle path regime where we don't go for extensive surgery, where we don't go for extensive conservative. What we do is we start every patient on ATT and rest for 18 to 24 months, and we observe the patient. So shouldn't we continue ATT and proceed with surgery? Correct, Stardust. So ATT will be continued, but we have to do decompression surgery as well. Okay, ATT will be continued. It will not be stopped. ATT will continue again, but decompression surgery immediately has to be the protocol. Okay, so maybe the way I framed the question was wrong. Correct, Stardust, you're right. We will have to continue ATT medications and then go for decompression surgery. Okay, but decompression surgery is the protocol here. So what I was telling you is in middle path regime, what we do is we give every patient ATT medications, we monitor them. If they have a cold abscess, we drain the cold abscess, and then every time they come for follow up, we look up on whether they've got any neurological deficits, we look at the symptoms, and then we decide whether we should go for surgical decompression or just give a complete regimen of ATTB medication. So if they're improving, then we can just continue with the medications and they'll get better. But in few indications, we'll have to go for surgery. And this is the main thing I want you to remember. What are the indications of surgery? Okay, the indications are these options here. The first option is not an indication, it's talking about biopsy. See, whenever you go for a TB spine case, just don't read the MRI report of the patient and the radiologist have given suspected TB spine, don't start the patient on ATT medication. That's not the protocol. The protocol is if there is a suspected TB spine patient, you have to do a biopsy and then you start the patient on ATT medications and treatment. Okay, so this is the protocol that we follow. So biopsy has to be done when there is unclear or doubtful diagnosis or when you want to confirm the diagnosis. Surgery, decompression surgery should be done when there is no improvement with medications after 3 weeks, when there is increased neurological deficits, when there is bowel bladder involvement, when there is a large abscess that is not responding to treatment, when there is instability of spine, which is rare but can occur if even the posterior elements get involved, instability of spine. And in cervical TB, mainly in cervical TB, if there is a big cervical abscess which is causing dysphagia or dysphonia, then you may have to go for surgery. Okay, so these are the indications when surgery is required. Now that you understood this, let's go to an INICET June 20 question, which again talks about spine TB. They're asking you indications for surgical intervention, including biopsy. Okay, including biopsy in pot spine are all except. Okay, so they want to know which is not an indication. The options are drug resistance, diagnosis unclear, doubtful diagnosis, cold abscess without neurological deficits, and progressive cauda equina evolving conus medullaris. This is a direct recall question from INICET June 2020. Stardust feels it's A. Shabir says it's C. Any other answers? Dr. Jain believes it's A. See, you will have questions like I've told you in the first session as well. In INICET, you will have questions where two options will be a little dubious. They'll feel very similar. Like the question given here. Here A and C, both of them can seem like the answer. Okay, Shahzad believes it's B. Diagnosis unclear. See Shahzad, in the option they've given including biopsy as well. So when there is diagnosis unclear and doubtful diagnosis, won't you go for biopsy? So if you're going for biopsy, then that does not rule out. Okay, so that's why they've given read the question. In the option they've given it including biopsy as well. So B cannot be the answer. So you have a doubt between A and C, like Shabir and Stardust have here. They have a doubt between A and C. So the most clear answer here, the best answer that you can choose is C. Because a cold abscess is never an indication for doing decompression. Cold abscess, you can do just abscess drainage and leave it to that, but you have to have neurological deficits. See, drug resistance, to some extent, if it is not possible, you might go for surgery as well. When we practice, in our practice, we go for surgeries in drug resistance cases as well, because they don't get better with ATT medications, even second line medications, and that is why at some point we might go for surgery. But a cold abscess without neurological deficits is definitely never an indication for surgery. So the answer here is cold abscess without neurological deficits. Is this clear? Now let me come to another question here. We are going for surgery. What is the name of the surgery? Dr. Jain already has given me this answer. He says it is anterolateral decompression. Anyone else? How to treat cold abscess? See, Dr. Jain, cold abscess can be drained, USG guided drainage, or even surgically you can do a drainage. It is like draining any other abscess. So you can do cold abscess drainage because they're more superficial. You don't have to go at the site of where the TB spine is and then drain the abscess. Cold abscess is somewhere more distant, no? You can just drain that cold abscess. And anyone can tell me what is the surgery? So Dr. Jain says it's anterolateral decompression. Anyone else has a different answer? Okay, anterolateral decompression, is it done from anteriorly or posteriorly? Do I do it from front or back? Dr. Jain, you're absolutely right. It's anterolateral decompression. But my question again is it anterior? Do we do the surgery from anteriorly or do I do it from posteriorly? Where is the incision placed? Okay, I'll explain this concept to you. So Dr. Jain was right. It is anterolateral decompression. So imagine that this is a TB spine that has undergone a TB. I mean, this is a vertebrae that has undergone TB spine. The green thing that you see is the pus that is present, or the granulation tissue, and the yellow thing is the cord. Now, the decompression is done from posteriorly. Don't get confused by the name. We do it through a posterior approach. We do it through a posterior approach. Through posterior, what do? We remove few structures. So let me mark that in pink here. So we know that vertebrae is involved. There is pus in the vertebrae. So we will remove as much of the vertebrae as we can, and not just the vertebrae. You know that in paradiscal, even disc is involved. So we will remove vertebrae. We will remove disc. Along with that, we will also, because we are going posterior to anterior, we have to remove few structures before reaching the vertebrae. Which are the structures? Which is this structure here that I am marking? Which is this structure that I am marking here? Now, the structure where we usually put screw, when we put a vertebral screw, which area do we involve? I had asked this to you in the last session as well, Shabir. Do you remember? Yes, it's pedicle. So pedicle is being used. Pedicle is being removed. Shabir, you're right, it is pedicle. Then even this transverse process we remove, and also we remove the rib. Here there will be rib, so we'll remove the rib as well. So this much we'll remove. Through this we'll be able to remove all the pus and granulation tissue. And the reason we call it anterolateral decompression, which Dr. Jain also said, we call this as anterolateral decompression, is because we're removing the structures anterior and laterally. Not because we're going from anterior, we're going from posterior, but we're removing structures anteriorly and laterally. Which are these structures? Vertebrae, disc, pedicle, transverse process, and also ribs. So all of these are removed, and this is the anterolateral decompression. Can you see what is marked in there are the parts that are removed? Rib, transverse process, pedicle, vertebral body, and disc. Affected disc is removed. So through this you can remove all of the pus and all the infected material. You get a good amount of decompression in this. Okay, so this is the anterolateral decompression done. Dr. Shimona, good evening. Welcome to the session. So the answer was decompression surgery. You were right. The answer for that question was decompression surgery. I hope you understood. Two concepts I've tried to clear in spine TB. One is about types of spine TB, and second is about surgery. Mainly what is a surgery and what are the indications of surgery and what is a middle path regime. Okay. So this much is important in spine TB. Now let's again go back to physical medicine and rehabilitation. And here a very important chapter in physical medicine and rehabilitation is musculoskeletal system. From here a lot of questions can come, which is again a superimposition with orthopedics. So what are the questions that come from musculoskeletal system? So let's see this question here. A middle-aged woman complaining of tingling and numbness over thumb, index and middle finger. Also she complains of clumsiness in carrying out fine movements of household work. Tingling is more prominent in the night. While asking history, clinician gives a history of Colles fracture previously. Which is the best test to diagnose this condition? So again, a two-layered question where one, you have to understand what is the diagnosis, and second, you have to be able to understand what is the best test for this diagnosis. Dr. Jain has straight away answered it as Durkin's test. Anyone else would like to answer? Give it a try. Dr. Jain, could you also tell us what is the diagnosis here? So let's try to solve the first layer. So like I've told you, whenever you're approaching a question like this, we need keywords. We have to identify certain keywords. So can you tell me what are the keywords here and what is the diagnosis you reach from the keywords? Stardust says it's Durkin's test. First, let's go to the diagnosis. What do you think is the diagnosis here? Cubital tunnel syndrome. Cubital tunnel syndrome. Okay. Anyone else with a different answer? Okay, Dr. Jain's corrected himself. He says it's carpal tunnel syndrome. Okay. Yes, Dr. Jain says it's carpal tunnel, not cubital tunnel. Stardust also is saying it's carpal tunnel syndrome where median nerve is getting involved. Okay, you're right. It is carpal tunnel syndrome. So which tests are done in carpal tunnel syndrome? we have Fallon's test, we have Durkan's test, and we have reverse Fallon test. So which is the best test is now the second layer of the question. So which is the best test? Initially we do Fallon's test. Okay, Shahzad, you're right, absolutely right, Shahzad. It is carpal tunnel syndrome. Dr. Jain says that initially we'll do Fallon's test, but the best test, if you ask me, it is Durkan's test. Stardust also says the same. So yes, you are all right first in diagnosing the patient, because a clinical scenario of carpal tunnel syndrome will be always like this. They'll always give you a middle-aged female. Usually females are more prone, 30 to 60 years. They'll have this burning pain and tingling sensation, mainly at the distribution of the median nerve, and pain is more in the night. Why? Because when they sleep in the night, their wrist goes into these kind of movements, and that is when the pain will get exaggerated, compression will get exaggerated, and late features you'll also have thenar muscle wasting. So you're all right, it is carpal tunnel syndrome, and in carpal tunnel syndrome we have 4 tests. We have Fallon's test, we have reverse Fallon's test, we have Durkan's test, and we have Tourniquet's test. So this is a Fallon's test where you ask the patient to keep his hand like this, and when he keeps this in this position, because there is compression of the median nerve, patients will have increased, that this tingling sensation or these features will get exaggerated. Then there is the reverse Fallon, mainly like a namaste sign. So these are 2 tests, Fallon and reverse Fallon. So this is a meme for you to remember, Fallon and reverse Fallon. If you followed the show, which was way back during my childhood, I think, I'm not sure whether you all seen this. So Fallon's and reverse Fallon's tests are somewhere you'll remember. But these 2 tests are done initially. They are not always the best test. So a best test is always when the test is specific. That is, when you do the test, you know that 80 to 90% of the chance the answer is the diagnosis. That is the most specific test, and the answer is Durkan's test. Yes, Dr. Jain, that is Sarabhai versus Sarabhai. So the Fallon's and reverse Fallon's test are tests that we might do initially when we are suspecting a case of carpal tunnel syndrome, because they're easy to do in clinics. But if you want to get a specific answer, mainly 80 to 85% specificity is seen in Durkan's test. Okay, Durkan's test is when you give compression. Where do you give compression? Where there is pathology. That is median nerve, when it goes under this ligament, under the flexor retinaculum, you have to press that area. You have to give compression for at least 1 minute. And when you do that, patient will talk about exaggerated symptoms. That same symptoms on the median nerve area will get exaggerated, and that is the Durkan's test. Okay, it is a Durkan's test, or also called as carpal tunnel compression test. Okay, these are the 2 names it's given, and this is the best test to diagnose a case of carpal tunnel syndrome. So all of you were right. The answer is Durkan's test. Okay, now let's go into another question from musculoskeletal disorder. A 45-year-old male presents with shoulder pain exacerbated during abduction between 60 to 120 degrees with relief. Tourniquet is nothing but you give compression through tourniquet. You put a tourniquet and give compression. That will again exaggerate the symptoms. That is the tourniquet test. That we will do in many cases of nerve compression injury or nerve entrapment syndromes. Simple test, nothing major about it. Okay, this question, a 45-year-old male complains of pain exaggerated during abduction between 60 to 120 degrees with relief noted beyond this range. Relief is noted beyond this range. On examination, there is pain during passive shoulder abduction, but both active and passive ROM are normal. Impingement test is positive. What is the most likely diagnosis? Now, Shabir says it's C, but yeah, before we go into the options, I want you to solve this in a layered fashion. Like I told you, I want you to learn the art of solving MCQs. So for that, let's think of keywords. Which do you think, Shabir, is a keyword that helped you arrive at this diagnosis of C? Yeah, Shabir, Stardust also says it's C. Correct. Okay. C might be the answer. I won't go into the answer now. But I want you to tell me what are these keywords that you were looking for here. Specific words that gave you the answer. Dr. Jain also believes it is C. I'm not commenting whether they are right or wrong, but I want you to know how you all arrived at this answer of subacromial bursitis. Relief beyond this range. Pain during mid-range abduction. Okay, 60 to 120 degree of abduction. What is the name for that? Hello, Dr. Aishwarya. Hello. Oh, sorry. 60 to 120 degree abduction. Correct. So, what is the name of the syndrome when there is pain from 60 to 120 degree? When this much arc is painful, what do we call it as? What do we call this as? Painful arc syndrome. Correct. It is called as painful arc syndrome. Before I answer this question, let's understand what is painful arc and why patients with painful arc syndrome have pain specifically from this 60 to 120 degrees. And also few other keywords is both active and passive ROM are normal and impingement test is positive. This is something you didn't tell me. You only told me about 60 to 120 degree. Other keywords are impingement test and the movements also. Okay. So look here. Whenever your shoulder goes throughout a range of motion, usually even the rotator cuff muscles will slide. As you can see here, there is sliding of these rotator cuff muscles along a tunnel. This tunnel that is there now is between, which bone is this? Acromion. Which bone is this? Coracoid. This is coracoid. This is acromion. So can you explain all four keywords? I'll tell you, I'll come back to the keywords, but I want you to first understand what is painful arc syndrome. See, painful arc syndrome and subacromial bursitis are not the same things. Painful arc syndrome has a lot more component to it. So to understand this, first see this animation. Can you see how these rotator cuff muscles, which are responsible for us doing this abduction, they slide along a coracoacromial tunnel. Coracoacromial tunnel. Between that small tunnel, you can see the sliding of the muscles, which is normally very smooth. But if something goes wrong in that tunnel, imagine there is a fracture, there is a bursitis, there is some malunion, all of that will compromise the tunnel. And when you compromise that tunnel, can you see here, when 60 to 120 degree movement is there is impingement of these muscles. Muscles of supraspinatus, infraspinatus, they're getting impinged, and that is why when I go to do this movement, I'll start having pain. I'll complain of pain between 60 to 120 degrees. This is called as painful arc syndrome. Not subacromial bursitis, this is called as painful arc syndrome, and this is the most common shoulder disorder, also called as impingement syndrome. This is the most common shoulder disorder, affects younger individuals, mainly involved in overhead working. Okay, so this classical thing for painful arc syndrome is 60 to 120 degree will be painful because of crowding of coracoacromial arch. Now, why is that impingement occurring? Let's understand the causes of painful arc syndrome. Causes can be naturally only if you have an abnormal acromion, that is, there is an abnormal shape and tilt of the acromion. If in overhead activity, sports people, when they get this eccentric loading of tendons, or any pathology in the subacromial space, can be subacromial bursitis, can also be calcific tendinitis, can also be supraspinatus tendinitis, can be malunited greater trochanter, can be acromion fracture, tendon degeneration because of aging, AC joint arthritis and spurring, and also in abnormal kinetics. If a person is doing abnormal kinetics of the muscle, they can also result in all of this. All of these causes painful arc syndrome. Okay. So in the option, if you see, the only one which is a condition causing painful arc syndrome was subacromial bursitis. Now, as for what Dr. Jain said, I explain all four keywords. See, one keyword I've already explained: abduction between 60 to 120 degree and relief beyond this range of motion. That is clear. Next thing is pain during this movement. When you're doing this passive shoulder abduction, there will be pain because there will be impingement. But why have I given this active passive ROM are normal? Because in rotator cuff tear also, patient will have pain from 60 to 120 degree. He will have pain, right? He will have pain. But also along with pain, he will not be able to do all these movements. He won't be able to do those movements passively and actively. So if active and passive ROM are normal, then it cannot be rotator cuff tear. Adhesive capsulitis also, we know that in adhesive capsulitis there is a lot of the frozen shoulder also, it is called as, there will be a lot of restriction and pain. So patient will not be able to initiate movement as well. So again, active passive ROM is not possible. So adhesive capsulitis is also not the option. Clavicle fracture, we know that in fractures we cannot do all of these movements. So these three are ruled out. So the answer is subacromial bursitis. Is it clear? Do you understand what painful arc syndrome is? Next time when they ask the question, they might not include subacromial bursitis. They might give you calcific tendinitis. That again is also the answer. Instead of this option, if they give you calcific tendinitis, that also is the answer. Okay, so this is painful arc syndrome. This is a concept that you need to know both in ortho and in cases of ortho and in PMR cases. Now, one more thing that I have not explained to you is what is impingement test. Can you all tell me which are the impingement tests that we do? What are the impingement tests mainly for painful arc syndrome or impingement syndrome? Neers test. Okay, Neers test is one of them. Dr. Jain is right. Any other test that you know of other than Neer's test? Any other test? Hawkins. Dr. Jain, you're absolutely right. It is Hawkins. Full form, anyone knows the full form? Is it just Hawkins test or is there another name? And anyone else knows the full name? Or Dr. Jain, would you like to complete that answer? So right, it is the Neer's sign and Neer's test. Two different things, Neer's sign and Neer's test. So Neer's sign, what you do is, you ask the patient to keep a forward flexion and then you do internal rotation. See, you keep it forward flexion and internal rotation. You try to do this internal rotation movement, and at this moment of internal rotation with this much forward flexion, patient will complain of pain in the subacromial space. He will complain of severe pain in the subacromial space. This is the Neer's sign. Okay, this is the Neer's sign. Now, after doing this pain, after eliciting pain, you give an injection into the subacromial space. You put a lignocaine injection into subacromial space, and again you try to do this movement. And if pain is better, then you know that this is because of impingement syndrome or subacromial space pathology. This is called as Neer's test. How will you be able to differentiate? See, Neer's sign stands for S. So only single test is done here. That is, you do this internal rotation. Neer's test, you do this internal rotation, you elicit pain, and after that you give an injection and then test again, the pain will get better. That is Neer's test, where you do the movement twice. Okay, so this is Neer's sign and Neer's test, both are done for impingement syndrome. The second one, like Dr. Jain said, is the Hawkins-Kennedy test. In Hawkins-Kennedy test, you ask the patient again to keep in forward flexion. You also ask him to keep his elbow flexed as well. So elbow, and there is forward flexion of the shoulder. Now the doctor will internal rotate, forcefully internal rotate like this. When he internal rotates, the patient will complain of pain, and this is called as the Hawkins-Kennedy test. Okay, these are the two tests that you do in impingement syndrome. And one important X-ray finding also I want you to know about acromial syndrome. So you will notice that at the subacromial tunnel, at that tunnel area, there will be this lucence, this whitening will be seen, and this whitening looks like our eyebrows. They look like eyebrows, and eyebrows are also called as sourcil. So we call this as a sourcil sign whenever there is acromial sclerosis, mainly seen in impingement syndrome. You will have acromial sclerosis, also called as sourcil sign. Okay, sourcil sign. Now treatment is very specific to the condition. Sometimes you'll give analgesics, subacromial injection to corticosteroids. If it is because of eccentric muscle movements, or in athletes you will do rotator cuff training, strengthening of rotator cuff muscles, stretching of these muscles. And if nothing is working, you will have to go for surgery, either subacromial debridement, decompression. If it is a bursa, you have to do a bursectomy. If acromion is abnormal, you have to go for bony acromioplasty, or if cuff is degenerated, you have to go for cuff repair. So these surgeries are tailor-made to the situation. Okay, so this was about painful arc syndrome. Now a little bit you need to know also about rotator cuff muscles and their tests. So this is a table I want you to note down. I'm going to talk about it later as well. Muscles and what are the tests. So subscapularis, we have belly press test, or also called as Napoleon sign. Lift-off test or Gerber's test is seen in subscapularis. Bear hug test again for subscapularis. For supraspinatus, the best test is Job's empty can test and full can test. Infraspinatus and teres minor, Patty's or Hornblower sign. Don't worry, just note down this table. Later on at the end of this session, I'll also talk about how these tests are done. I'll talk about them later. Also, if you want to know generally in orthopedics and PMR what are all the tests used, you can remember this table. Please take a screenshot or write down this table, all the tests and all the conditions that are there. So this will be a quick revision when INICET exams come near, all the important clinical tests in orthopedics and PMR. Okay, so now let's go back to another musculoskeletal question. This is again an AIMS question asked from PMR. A counterforce brace is used in which of the following condition? Is it tennis elbow, ankle sprain, ulnar claw hand, foot drop? Fairly simple question. It's talking about a brace called as the counterforce brace. Which condition is it used in? Dr. Jain says that it is tennis elbow. Anyone else? Shazad, Shabir, Stardust. What do you think the answer here is? So you can guess. You can always guess. There is no wrong points here. Nothing. I'm not going to criticize you. Shabir is not sure what the answer is. Okay. Fine. So this was a question asked in the AIMS about counterforce brace. So counterforce brace we use in tennis elbow. Foot drop, no, foot drop is a different splint. I'll talk about that splint later. But this is used in tennis elbow, Shabir, in lateral epicondylitis, which is mainly chronic tendinitis. Dr. Jain, correct? Lateral epicondylitis it is. Okay, Dr. Jamula says it's D, okay. It's not foot drop. See, foot drop splint is different. I'll show you what a foot drop splint is later on as we go forward. Okay, Shehzad also thinks it's foot drop. Okay, it's not foot drop. Foot drop is a different splint. Okay, Stardust, you're right, exactly right. Lateral epicondylitis. See, what is lateral epicondylitis? It is chronic tendinitis of common extensor origin. If they ask you which tendon in specific, you know that it is extensor carpi radialis brevis, commonly seen in 30 to 50 years old patients who do this repeated wrist extension movement. Like in tennis, whenever they're hitting a backstroke, whenever they're doing that, they have this wrist extension movement. No, same wrist extension movement whenever you're doing for different movements also, you will start getting this tennis elbow kind of pain. Okay, so what is the test that we do in tennis elbow? Anyone would like to answer? I'm showing you also what this is the test that is done in tennis elbow. I showed you in the table as well. What do you think is the test that we do? There are two tests. If you can answer one of it also, I'll be happy. If you can answer both, amazing. Dr. Jain says it's Cousin. Okay, someone says it's Cousin. Shabir also says it's Cousin's test. Anyone knows the second test? See, it's INICET. They love to ask bouncers. They love to ask the other option, not the conventional one. So anyone else knows this other test that we do? See, what are we doing in this Cousin's test? We are Mills manure. Okay, Mills manure. Okay, so what we do in a case of lateral epicondylitis, we are trying to test wrist flex extension, and also we're palpating the area where pain is, lateral epicondyle. So when we do this is called as Cousin's test. Okay, one is Cousin's test. The second test, the one that I wanted to talk about, is Maudsley's test. Okay, Mills is also the right answer, but Maudsley's is one of the ones that is mainly used. Maudsley's test and Mills test. Okay, so three tests in together. Dr. Jain was right. Mills test is something I didn't expect you to know. Mills test, I thought Maudsley's and Cousin's. Very good, Dr. Jain. So one more test that I want to talk about is Maudsley's test, where instead of doing just wrist, you're doing only middle finger. So only doing middle finger extension. With that, you're eliciting pain. Thank you, Dr. Kalpana. So this is the three tests that we do: Cousin's, Maudsley's and Mills manure. These are the three tests. Mainly you have to remember Cousin's and Maudsley's test. Okay, management we all know is NSAID is an activity modification, extensor strengthening activities are done, and then we use this brace. We use the brace mainly to do what? See, we'll place this brace like this, not at the elbow. We place it at the bulk of the extensor muscle. We place it at this bulk of the muscle, so that this muscle mobility, this irritation because of movement of the muscle is not happening. We are arresting that movement to some extent using this brace, which is called as either a tennis elbow brace or a counter force brace. We are trying to reduce the force of the extensor muscle, called as a counter force brace or an tennis elbow brace. So this is what a counter force brace is. Okay, so that was about PMR. Now let's come back to orthopedics again. And the one topic that I did not discuss in orthopedics, mainly in the previous session, was bone tumors. Now the problem with bone tumors in students, I've noticed, is that they know a lot of theory about bone tumors. They know every theory about bone tumors, but when a question is given to them, a clinical question is given to them, they are not able to diagnose the tumor, and that is the problem. For them, like this meme here, all tumors look the same. So what I've done in my MEDES videos, in my lecture videos, is I've made a session called as Understanding Bone Tumors, where I've not talked about theory of bone tumors. I've not talked a little about theory also. I've only talked about a systematic approach of how to go to the tumor, how to diagnose a tumor. So it is a 45-minute lecture. If you want, you can go back to my MEDES session. The free trials of those videos are available. You can go to that and see that class and learn about how to just diagnose bone tumors. Theory, I'm sure all of you will be very good at memorizing, but try to learn how to go into the diagnosis. Okay, so I'll give you a demo of how we do it. So let's look at this question here. A 16-year-old child underwent a knee X-ray. Other options for treating tennis elbow. See, tennis elbow majorly, first treatment that we'll do is we'll give rest, We'll give anti-inflammatories because early stages there will be inflammation. So anti-inflammatories will be giving. Later on, what we can do is we can give them a brace. If they want to continue working with tennis elbow inflammation, we'll give them a brace to arrest that. If that also doesn't work, the next step, although in literature they do not advise it, the next step given in your textbooks is we can give steroid infiltration. Steroid infiltration is one of the alternatives that are available, but the problem on long-term steroid is that muscle will undergo degeneration. Okay, so now what we've come up with a new theory of giving platelet-rich plasma. PRP is something we use. We give it at the insertion site where the muscle is getting degenerated. In later stages, if the muscle is completely degenerated, what we can do is we can excise that muscle and allow it to go more proximally. Okay, that is a salvage procedure that we can do. Surgical option, not usually preferred many times, but what we can do is we can cut that, we can maybe distalize the common extensor origin. Okay, that is a surgery that we can do along with some amount of debridement for the inflammation. So this is generally the protocol we follow in cases of tennis elbow, but hopefully in most cases it does not come to salvage procedure. It is usually left till only maybe PRP injections, which now work more beautifully. So this is what we can do. Dry tapping, why would you do dry tapping? I'm not familiar with that. Okay, maybe we can discuss that later on. So this is general protocol, Shazad, that we follow, but I will come back to your dry tapping thing if you can tell me more about it. So now coming back to this question here, coming back to bone tumors. See, I want all of you to try this answer. I want you to at least give me your mindset. I want to know how you diagnose bone tumors, and hopefully I can make it better, or I can improve your technique of improving your diagnosis skills. Okay. So 16-year-old child, proximal tibia, you're seeing this big lesion that is there. Giant cell tumor, chondrosarcoma, chondroblastoma, and fibrous dysplasia are your options. Dr. Jain says it's chondroblastoma. Anyone else with a different answer or a same answer? Anyone else who agrees? Shabir also says it's chondroblastoma. Okay, Shabir, Jain, and meanwhile you can keep answering everyone. I want you to know your approach. Why do you think that this is chondroblastoma? How did you reach the diagnosis? Age less than 20 years, fair enough, but most tumors are less than 20-year age. Okay, we'll take that, age. Any other criteria that you take into consideration? Epiphyseal, right? Dr. Jain says it is epiphyseal, correct. Location of the tumor is also important. Any other thing that you took into consideration, Dr. Jain? Yes, location, correct. Location is important. So right, your approach is very right. Dr. Jain, Shabir, both of you are absolutely right. Stardust also, epiphysis, very good. So you solved this answer. Stardust says whether the epiphysis is fused or not. Yes, Stardust, you're right, mature or immature bone. So this much will give you the answer, but I'm not talking about just this bone tumor, but any bone tumor, if you get, this should be your approach. The approach is to identify these many criteria, and I've given it a mnemonic ABLE PSM. ABLE PSM. Where A stands for age, like Dr. Jain said, age is one criteria, which bone is another criteria, location is the third criteria, eccentricity is another criteria. Eccentricity meaning whether it is central, whether it is cortical, or whether it is eccentric. Then it is if periosteal reaction is present or not, if there is any special reaction, and lastly matrix. And I'm not telling you that you should be able to diagnose all of this in that. At least try to diagnose 3 or 4, and with these I'll give you beautiful tables for each of these criteria. If you just put them in those tables, you'll be able to diagnose the answer. You don't even need to know what chondroblastoma is, what chondrosarcoma is, you'll be able to answer this. For example, let's look at it in this case. So here, let's put the criteria of ABLE PSM. Although you already given me the answer, please cooperate with me here. Let's try to solve this. So age, like Dr. Jain said, is less than 20 years, which is not giving us a lot of hint. Next is the bone. Which bone is involved here? Dr. Jain, Dr. Shabir, Stardust. Which bone is getting involved here? Tibia, yes, it's proximal tibia that is involved. And like you told, the location is epiphysis. Location is epiphysis, and eccentricity we are not sure. It can be central or it can be cortical. So let's not mark that because we don't know. Periosteal reaction is not seen. Special reaction also, I don't know much about it. Matrix, can anyone tell me what matrix is seen here? Anyone who can see, there are different types of matrices. If there is a cloudy type of bone inside, we call that as osseous matrix. If there is some amount of cartilaginous things, like you see these popcorn calcifications, then we call them as calcified cartilage. If it is pitch dark, then we call that as then we call that as a kind of lucent one. If fibrous, it will be ground glass. So which do you think this is? Is it bony? Is it chondroid? Is it ground glass? Or is it pitch black? See, can you see some things are here? Some calcification is here. Okay, no one trying to attempt that. Okay, fine, it's okay. So chondro, okay, Dr. Jain says he sees some kind of chondroid matrix here. So that is what you have to write down, or at least mentally think of. You have to look at where the location is. So I know this location is epiphysis, so I'll write down what and all I know. I know this looks like a benign tumor. I'll tell you what are the features of benign and malignant tumor. I know this looks like, yes, Stardust also believes it's chondroid. MD Nafis also believes it's chondroid, correct. So it looks chondroid, correct. So benign is something I know. Epiphyseal is something I know. Chondroid matrix is something that maybe, I guess it is chondroid matrix. So these are my 3 observations from this. Now let's look at each of the criteria. So first criteria is benign or malignant. How do you make that sure? Benign will have narrow zone of transition, well-defined sclerotic bone, lack of soft tissue mass, there will be solid periosteal or no periosteal reaction, and some little bone destruction, not major. In malignant, there will be interrupted periosteal reaction, there will be severe bone destruction, there will be soft tissue mass, and wide zone of transition will be present. So looking at this tumor, it looks benign. We are sure of that. It is benign. Then let's look at location, like Shabir and all of them told, epiphyseal tumor. So what epiphyseal tumors do we know? This is the chart for that. The mnemonic here is GC, where G stands for giant cell tumor, C stands for chondroblastoma. So these 2 is something that you have to remember. GC, okay. So in giant cell tumor, mainly it is seen where, see, look at this is giant cell tumor. It is seen when the physis is closed, that is, it's seen in skeletally mature patients. It is seen in skeletally mature patients. See, Dr. Jain, there might be a lot of other tumors that are involved, but this is more exam specific for you. Because location, no, you have to remember few tumors and their locations. So epiphyseal, I think you just have to remember GNC. Okay. So ECG, you mean epiphyseal, giant cell and chondroblastoma. Is that what you're saying? Okay, that seems like a better mnemonic again. Okay, Dr. Jain has a better mnemonic than me. It is ECG. Okay, or GC, whatever you want to remember. So giant cell tumor is seen in skeletally mature patient, and chondroblastoma is seen in skeletally immature patient. Okay, so in our case, let's go back to the x-ray here. Can you see that there is a physeal plate that is still open? So this is a case of chondroblastoma. Only by just one criteria we've been able to diagnose it as chondroblastoma. Now if you want to confirm, let's look at matrix as well. Matrix, again, osseous matrix, usually you will see osteoid based tumors. Chondroid matrix, you'll be able to see chondroid tumors like chondroblastoma, chondrosarcoma. So chondroblastoma can be the answer based on the matrix as well. Can't be fibrous, can't be lytic. Okay, so we've solved this. This was fairly simple. Just by using 2 criteria, we've been able to diagnose it as chondroblastoma. Is this criteria clear? This was a simpler form. Now let's go into a little bit more complex one. Now here again, a child underwent an x-ray for right shoulder pain. In the x-ray, a lesion was noted. What could be the diagnosis? And they've shown you this is your image. Is it aneurysmal bone cyst, giant cell tumor, simple bone cyst, and chondroma? Anyone would like to answer? Okay, Dr. Jain believes it's aneurysmal bone cyst. Shabir believes it's simple bone cyst. Stardust also believes it's simple bone cyst. Okay, let's go into these criteria again for this question as well, and the criteria again remains the same. ABLE PSM, that is age, bone, all of that. Okay, Sakshi believes it's C again. Okay, the criteria again I've used here. Through the criteria I can tell you, so age again is not of any problem. Child is mentioned, so age is not a criteria that we can use. Bone, which bone is it? It's proximal humerus. It's proximal humerus. Then what do we have? What clue other we have? Is this epiphyseal, diaphyseal, metaphyseal? What is this tumor? Talk about location. What location is this tumor? Metaphysis. Yes, you're right. It is metaphysis. Then comes eccentricity. Eccentric. Do you think this is a central tumor? Is it present centrally? Is it eccentric or is it stuck to the cortex? See, three types I'll tell you. One is central like this. Another is eccentric like this. And third is cortical like this. Which type is it? Central. Yes, central. Correct. So you're getting the hang of this. It is central. Then PSM stands for periosteal. Periosteal reaction is not seen. Special feature that you can see is that this cyst is very clear. This cyst is almost clear. There is no evident cyst that you see. There is no cyst that is seen. One second. Okay, so there is no cyst that you see. It is almost clear. Central, correct. You're right. It is central. So there is a uniseptate clear cyst. Okay, that is a special feature. And matrix here is not very clear. You can't see any matrix that clearly. So this is what I've got from here. Non-septate cyst, central, proximal humerus, metaphyseal, benign. Do you all agree with me? Anyone who believes I'm wrong with the criteria, anyone who reads it a little differently, is these things clear? See, if any tumor comes, no, you should be able to think like this. Not all. Maybe you don't get non-septate cyst. That is okay if you don't get non-septate cyst. But if you can even think of central, proximal humerus, metaphyseal, that is enough. And I'll tell you how. So this is the mnemonic that I commonly use for metaphyseal cyst. Dr. Jain or someone else might have a better mnemonic, and I'll be happy if you have a better one. But this is a mnemonic that I commonly use. That is sofa or chair in metaphysis. And all the metaphysis tumors are simple bone cyst, osteochondroma, non-ossifying fibroma, aneurysmal bone cyst, osteosarcoma, chondrosarcoma. Now looking at this, I know it is benign tumor, so I can rule out osteosarcoma and chondrosarcoma. So I'm left with four. Aneurysmal bone cyst, non-ossifying fibroma, osteochondroma and simple bone cyst. Now let's look at another criteria, that is central. We all agreed that it was central. So let me go to central now. In central, can you see which tumors are central? It is simple bone cyst, enchondroma and fibrous bone cyst. Which is eccentric and expansile usually. It is GCT, that is giant cell tumor, and aneurysmal bone cyst. Which is cortical. Cortical is non-ossifying fibroma and osteoid osteoma. Please note this down, take a screenshot or whatever, but please remember this is the criteria to follow. So based on these two charts itself, have you diagnosed it, Dr. Shah? Dr. Jain, I want to come back to you now. So you know the metaphyseal tumors, you know which is central. So can you now correlate and tell me what the diagnosis here is? Do you still think it's aneurysmal bone cyst, or has your answer changed, Dr. Jain? Do you think it's something else? Because see, central tumors are these three. Okay, see, the one thing common in this chart, do you notice, is yes, Dr. Jain is right. It is simple bone cyst. Here also simple bone cyst is seen. Here also simple bone cyst is seen. So the answer here will be simple bone cyst. Okay, if you want to further confirm, if you want more criteria to confirm, then remember even the most common location involved, and this is enough. If you remember this chart, now you will be able to remember a lot of them. Like in skull, if they show you a tumor, it is either eosinophilic granuloma, METS, or myeloma. If they show you frontal sinus, it is ivory osteoma. If they show you mandible, it is amyloblastoma. If they show you proximal humerus, which in our case was the option, it is unicameral bone cyst, or also called as simple bone cyst, and chondroblastoma, one of these two. Spine, pelvis, all of this is mentioned. So you can take a screenshot of this. This will help you also to diagnose. So here again, simple bone cyst is in the option. So we can confirm that this is simple bone cyst. Even if this is not enough, let's go into special features. So these are all the special features I want you to remember. Can you see? Unicameral non-septated tumor is only one, that is simple bone cyst. That is only one, simple bone cyst. So we've diagnosed it and we've double confirmed that this is simple bone cyst. And if you can remember this protocol, you won't have this confusion. You'll always be arriving at the right diagnosis, and then the second layer you might have to buy out some theory from simple bone cyst, which is fairly easy for all of you. So the answer here is simple bone cyst. Okay, let's solve another question. This is a 35-year-old man presented with knee pain. The x-ray of his knee joint is given below. What is the probable diagnosis? Options here again are chondroblastoma, aneurysmal bone cyst, osteoclastoma, simple bone cyst. See, if you diagnose the answer, you can tell me. Even if you don't find that in the options and you think there is an answer that you know, you can tell me. Even if you tell me the criteria, I'll write down. If you can think of those criteria, able PSM, what criteria do you see? Tell me those criteria at least. Stardust says it's C, osteoclastoma. Dr. Jain also says it's C. Okay, so everyone agrees it's osteoclastoma. What is another name for osteoclastoma? GCT. Correct, Sakshi, you're right. It is GCT. So this is a case of GCT. How do we arrive at the diagnosis again here? It is, we know that this is a 20 to 40-year-old man. Here again, age is also important because age will also help you. I'll show you the chart that says about age. Epiphysis again, and eccentric also, and expansile as well, and distal femur, and also mature. This patient, skeletally mature patient. So it is giant cell tumor. Now age wise, if you want to remember, this is the chart I will ask you to write down. So 0 to 20, no, most tumors are 0 to 20. If you want to remember MCQ, most common between 0 to 10 years is Ewing sarcoma. Between 10 to 20 years is primary osteosarcoma. Okay, primary osteosarcoma. 20 to 30 years mainly is fibrous dysplasia. 20 to 40, like in our option here, mainly you can think of giant cell tumor. 40 to 60 usually is chondrosarcoma or secondary osteosarcoma. Main reason can be Paget's disease, and more than 60 is usually multiple myeloma, METS or chordoma. So this is a chart that I want you to remember for age. Few tumors can be diagnosed just by age. Okay, giant cell tumor, not just because it's 20 to 40, there are other criteria as well. And Dr. Jain says 3 E's. I'll ask you later what those 3 E's are. First, let's come into the diagnosis. So epiphyseal tumor, we know that is ECG. Let's take Dr. Jain's mnemonic here. Epiphyseal tumor is ECG. C is chondroblastoma, which is in skeletally immature patient. Giant cell, it is skeletally mature patient. So we've arrived at the diagnosis of giant cell tumor, and this is a very important question. Osteoclastoma or giant cell tumor is something that I want to discuss in detail. And why is that? Because INICET examiners love asking questions about giant cell tumor. In the last 7 years of papers that I've seen, maybe there has been one question from Ewing sarcoma, one question from fibrous dysplasia, and maybe one question was there from chondroblastoma. So these were just the 3 bone tumors that were asked. But repeatedly every year, the one bone tumor that was always asked was giant cell tumor. The question was not the same. Different questions, more complex questions were also asked. But giant cell tumor was a recurring theme in all papers, and that is why I want you to know everything about giant cell tumor. I want you to know giant cell tumor in a little more detail, maybe little bit till the PG level as well, because they ask questions from this. Now look at this question here. This is again a recall question, was asked in one of the papers. Which of the following is correct about the lesion shown in this image? Your options are 30% malignant transformation, can occur in metaphysis in children, most commonly occur in ages 40 to 60 years, ground glass opacity is diagnostic. Okay, diagnostic. Anyone would like to attempt this? See, even you can tell me which is incorrect as well, which you believe is completely incorrect is also fine, but please contribute to the discussion. Let's understand which do you think is right, which is wrong, which you don't agree with at all, and then let's arrive at the diagnosis. Stardust believes it's B. Dr. Jain says it's D. Okay. Okay, Stardust believes that option A is completely wrong. Sakshi says it's B again. Debraj again says it's B. Okay, 20 to 40 years, so C can be ruled out. So C, okay, C can be ruled out again, that we've already discussed. Giant cell tumor is more common in 20 to 40. It's benign. Yes, Dr. Jin, it is benign, but don't you know that giant cell tumor has malignant transformation? Soap bubble is diagnostic. Okay, locally aggressive. Correct, Dr. Jin, you're right. It is locally aggressive. Yeah. So they are talking about the percentage of malignant transformation. Shabir believes A and C are wrong. Dr. Nilesh says D is the answer. Yes, I think most of you are right here. So 30% malignancy, like Stardust told, is wrong. It's wrong option. Most commonly occurs in age of 40 to 60. Again, Stardust told it's 20 to 40. Yes, this is also wrong. Ground glass opacity is diagnostic. See, ground glass opacity is seen. But is it diagnostic? When you see ground glass, will you definitely say it is giant cell tumor? No. You will never say it is definitely true. So this again is wrong. The answer is can occur in metaphysis in children. Although it is an epiphyseal tumor, it can be in metaphysis in children. So this is the answer. Okay. So now that we understood this, a little complex question, I agree. But the reason I put this question, it's INICET recall question, is that they can dig. I don't agree with B also, but this is the best you could come up with. Yes, starters, you're right, absolutely right. That's what I'm trying to focus here. See, what we know normally in giant cell tumor, INICET papers have gone beyond that. So now questions are becoming more complex. They're asking about exceptions. They're asking about these small hidden facts which we normally don't study about giant cell tumor. And that is why I want to teach giant cell tumor to you a little more in detail. So we know giant cell tumor is also called as osteoclastoma. It is a benign local aggressive lesion. Like Dr. Jain said, it is a locally aggressive tumor. It is epiphyseal, seen in skeletally mature patients. Which is the most common site? Distal femur, more than proximal tibia, more than distal radius. And it is the most common tumor of distal radius. I've shown you in that image also that distal tumor, any tumor comes, you mark it as GCT. Okay. Now we know, like Dr. Jain said, E's are very common with giant cell tumor. He told me 3 E's. Dr. Jain told me 3 E's, but I'm going to ask you further 6 E's. Can all of you tell me the 6 E's of giant cell tumor? Dr. Jain, you can start with your first 3 E's that you know, and then maybe we can add more E's to it. Which are the E's that we all know about? Eccentric, right? Eccentric. Expansile, correct? We've got 2. Epiphyseal, yes, Dr. Jain Stardust, you're right. Any other E's you can think of? Eggshell cracking. Sakshi, you're absolutely right. Eggshell cracking. So we've got 4, 2 more. Extended curettage. Beautiful. Dr. Jain, you're right. Extended curettage is a treatment for giant cell tumor. One more. I'll give you a clue. So this is mainly talking about epiphyseal tumors are seen in children and elderly. Giant cell tumor is seen in elderly. So the other E is elderly. Okay. So 6 is epiphyseal, elderly, eccentric, expansile, eggshell cracking, and treatment also is extended curettage. And this is something I want to talk about, and I strongly feel that this can be an INICET question in the coming exam. What is extended curettage? Exactly right. What Stardust was asking is something I want to ask you guys. What do you think is extended curettage? Is it just going more than the normal curettage, or is that something else? Dr. Jain, elderly, when we're talking about, we're talking in respect to epiphyseal tumors. Between chondroblastoma and GCT, GCT is seen in elderly patients and chondroblastoma seen in relatively younger patients. That is what elderly means. Not that 60 to 80 year elderly, only talking about epiphysis. See, I cannot tell 20 to 40 is elderly because then that is offending my age and your age as well. So I don't believe it is elderly. But if you want to remember epiphyseal tumors, elderly and children, you can use this E. Okay. Can someone tell me what is extended curettage? Dr. Jain, you answered this question, extended curettage. Can you tell me what it is, or at least what components do we use to do extended curettage? See, what most students think is curettage is normal curettage. Extended curettage is when we do curettage more than required, that is extended curettage. But that is not the answer. What is extended curettage? What are these components that we use in extended curettage to get better debridement or to remove tumor cells better? Anything anyone knows? Nitrogen, yeah, yes, you're right, Dr. Jain. Anything else that you know? Very good, Dr. Jain. Okay, so I'll tell you, starters to answer your question. Acrylic, okay, so curettage followed by installation of some chemical. Yes, Shabir, you're right. Curettage followed by installation. So starters, see, extended curettage, look at this image here. So what happens with GCT, main problem with GCT, because it has a lot of septations inside them, is even if we do curettage of the tumor, at the end of the curettage, the bone will look something like this. There will still be some remnants, some amount of tumor cells will still be remaining. So curettage, we decided long time ago, was not the correct option for treating GCT, because some remnant cells will remain back, and that is not good, because GCT can go for malignant transformation as well. So we had to do something else. Beyond curettage, we had to do something else. So we started using not just chemicals. Shabir is right, we use chemicals as well. Not just chemicals. Grafting is not the option, Dr. Jain. Grafting will not remove tumor cells. No, we have to do extended curettage. And how do we do that? We use some kind of component, either phenol or liquid nitrogen, like you said, or bone cement, because even bone cement has this exothermic reaction which will cause extended curettage. So you can use that, or you can use high speed burrs. Nowadays in the market you get these high speed burrs, or argon beam. You can use all of them. This will cause extended curettage. Can you see now how all the tumor cells are removed, and then you are left with a lot of debris. You're left with a dead space that you have to fill. That you can fill in two options. One, like Dr. Jain said, you can use bone graft, or you can use bone cement. Two things you can use to cover. So this whole procedure is called as extended curettage. Did you understand, Stardust, what it is? Extended curettage, extended meaning adding some extra thing. What are those extra things? I want you to remember that. It is phenol, liquid nitrogen, bone cement, high speed burr, and also argon beam. Remember these 5 things. Okay, these 5 things are used in extended curettage. Why is it done? To reduce recurrence rates. And then you can use bone grafting. You can add bone, you can even use bone cement if there is a big gap and you don't have enough bone graft. So this was extended curettage. This is one concept in GCT that they might ask about, very likely. Other few MCQs that you need to know is that local recurrence in GCT is in 20% cases. It is in 20% cases. Mutation of one gene is also important. See, in 92% cases of GCT, you have H3F3A gene mutation. Again, this is a little high level, but because INICET loves asking questions from GCT, I am including them. Please note them down, important for your INICET exam. H3F3A gene mutation. Then in less than 5% cases, we'll have malignant transformation. Like Stardust mentioned, less than 5% cases will have malignant transformation, and usually they'll go into secondary osteosarcoma most of the time, fibrosarcoma, or malignant fibrous histiocytoma. Now metastasis to the lung is 3%, and it is more in distal radius GCT than lower limb GCT. Remember this. Metastasis to lung is more common in distal radius giant cell tumor than lower limb giant cell tumor. Okay, so these are few MCQs that you might have to just by heart, because no way of logically remembering them. Okay, so this is few MCQs. Few other things to remember is radiological grading of giant cell tumor. Don't need to know the grade, just remember the name, Campanacci's grading. Campanacci's grading is the grading used in giant cell tumor grading. And also there is a pathological grading. Histological grading is Jaffe's grading system. I'm sorry, I'm making it a little more complex for you, but because it's INICET exams, they might ask you these things, so remember this. And one very important concept which students always get confused with, when we ask them which is the pathognomic cell in GCT, they'll always say, because it is giant cell tumor, the giant cell is the pathognomic cell, but that is not the answer. The pathognomic cell, the main tumor cell, is a stromal mononuclear cell, not the giant cell. Okay, in giant cell tumor, pathognomic cell is a stromal mononuclear cell. Although giant cells are present, they are not the pathognomic cells. And last thing, yeah, stromal cells are the pathognomic cells, not the giant cells. Okay, not the multinucleated giant cells. The last thing is a sandwich technique. So what happens, because giant cell tumor is an epiphyseal tumor, so in children, if you are doing this extended curettage, so you'll have this epiphysis, and you'll do extended curettage. You'll remove all of this whole bone you'll remove here. Now you don't have this much graft to put in the area. This much whole area that you've removed, now, you don't have enough graft to put there. So what you will do is, you can't put bone cement in the whole area. You can't put bone cement because bone cement has exothermic reaction. Now this epiphysis, if it is in touch with this exothermic reaction, epiphysis will also be damaged. So what you do is, whatever bone graft you have, you put those bone graft here near the epiphysis. You put them here. Then at the physeal region, you put a gel foam. Here you put one gel foam, and in the rest of the area, you can put bone cement. Here you can put bone cement. And this technique, because 3 layers are involved and there is a foam that is kept in between, or gel foam that is kept in between, we call this as the sandwich technique. Sandwich technique is done to protect the epiphysis, mainly in children. So this is another complex thing, but again, high yield topic. So that's why we are doing this sandwich technique in giant cell tumor. Is this clear? This is about giant cell tumor. And also a very basic mistake that most children do is they usually don't differentiate between GCT and aneurysmal bone cyst. And for them, there is no way of teaching them. Just this one meme would be enough, that please look at where the epiphysis is. If epiphysis is involved, it cannot be aneurysmal bone cyst. Although aneurysmal bone cyst will be expansile, will be eccentric, but you have to be able to at least you have to be able to differentiate between aneurysmal bone cyst and giant cell tumor. Okay, there is no doubt in this. Now let's go back to PMR. Let's talk about amputation. In PMR, let's talk about amputation. Mainly 2 principles. One is principle of amputation. Next is orthosis and prosthesis. These are the 2 chapters that I want to cover. Mainly first, let's talk about principles of amputation. So look at this question here. Which of the following is true? Myoplasty is the direct suturing of muscle or tendon to the bone or periosteum. Myodesis is not effective in stabilizing strong muscles needed to counteract strong antagonistic muscle forces. Myodesis involves the suturing of muscle to muscle over the end of the bone, or distal stabilization of muscle is more secure with myodesis than with myoplasty. Which do you think is the answer here? I hope you're all clear with what is myoplasty, what is myodesis. Anyone would like to guess the answer? Debrad says it's B. Myodesis is not effective in stabilizing strong muscles needed to contract strong antagonistic muscle forces. Dr. Jain believes it's D. Okay, Shabbir again believes it's B. Anyone else would like to try? Also, another follow-up question, what is myodesis, what is myoplasty? Can you shortly put it up? Stardust says it's C. Myodesis involving the suturing of muscle to muscle over the end of the bone. Okay, so I think there is a bit of confusion as to what myodesis and myoplasty is. Okay, Stardust has never heard these words ever. So let me tell you these words and what do they mean. So what do we do normally when we do amputation? After doing amputation, what we have these muscle groups. These muscle groups which are not attached to anything. Imagine you're doing a above knee amputation. After you do amputation, you'll have a picture like that, like this image here, where you have a bone, you have these muscles which are not attached to anything. Their insertions are gone. Now this muscle can be attached in two ways. One, you can attach this muscle to the periosteum or the muscle of the antagonistic muscle, or you can attach this muscle to the bone or the periosteum of that bone, as it's done here. Can you see here? They've been attached to the bone itself. The muscle has been attached to the bone itself, and this process of attaching the muscle to the bone or the periosteum of the bone is called as myodesis. It is called as myodesis. Okay, this is a very good fixation. Here the muscle will sit very tightly. There will be good stabilization of the muscle when you attach it to the bone, because you're doing a transosseous fixation. There'll be very good attachment. So this is myodesis, suturing of muscle or tendon to the bone, and this provides a stronger insertion as it is sutured to the bone and it is tied in tension. Okay, but one problem with myodesis is if patient has a peripheral vascular disease where his vascularity is already compromised, this tight closure will not help the vascularity, and that is why myodesis is prevented or contraindicated in ischemic limbs, because it compromises blood supply. Okay, so this is myodesis. Another thing is to do myoplasty, where you are fixing the muscle to another muscle counterpart, antagonistic muscle. This is called as myoplasty. Okay, plasty, you're joining it with another muscle. So myoplasty, where you're suturing the muscle to the periosteum fascia of the antagonistic muscle. This is less stronger than myodesis, but it is preferred in ischemic limbs like peripheral vascular disease. So now that you understood this, going back to the question again, tell me now, what do you think the answer is? Option A is telling myoplasty is suturing of muscle or tendon to bone or periosteum. That is wrong. That doesn't seem right. So I'll mark that as wrong. Next, myodesis is not effective. So we know that suturing of muscle, this is muscle tendon to the bone. This is myodesis, not myoplasty. Next, it says that myodesis is not effective in stabilizing strong muscles. It is effective. It is a very good way of stabilizing. So this is again wrong. Myodesis involves suturing of muscle over the endo. No, this is myoplasty. So this is again wrong. So the answer is D. You're right. Debraj, you're right. It is D. Dr. Jain, it is D. So I hope you understood what myoplasty and myodesis is. The very important principle of amputation. Have been asked as a NEET PG question, not been asked in INICET till now, but they might ask you this time. Okay. So this is the concept. Now let's go into orthosis and prosthesis, and there are a few orthosis processes I want to discuss about, because nowadays there have been a lot of image based questions on splints, on braces and all of them. So let's try to solve this question. A 36-year-old patient comes with a D12 stable fracture which was managed conservatively. So a spine surgeon has seen this case and he's told that you can manage this conservatively. Which do you think will be the best brace? When you tell the patient to slowly mobilize maybe after 2 weeks, which is the brace you will use? Boston brace, Taylor-Knight brace, Ash brace, lumbar corset brace. Now let's approach this question. Even if you know which is wrong, you can tell me which is definitely not the answer. Please put up in the comment box and I'll start ruling out the answers as well. Shabir says it's B, Taylor-Knight's brace. Anyone else with a different answer, or anyone agrees with Shabir? Okay, KK says it's B, Taylor-Knight's brace. Any other answers? Dr. Jain also believes it's Taylor-Knight's brace. Okay, so everyone has a common consensus that it must be Taylor-Knight's brace. Someone, Dr. Jain again says C as well. Okay, Ash brace, fine. So most of you believe it's Taylor-Knight's brace. So let's understand spinal orthosis. The concept behind this question is to understand different types of spinal orthosis. This is a Boston brace, like I've shown you in the previous session as well. Boston brace looks like a bridal gown, where is Boston brace used in? Which condition is it used in? Do we use them in fractures or somewhere else? Where do we use Boston brace or modified Boston's brace? Scoliosis, Shabir, you're absolutely right. So Boston brace is used in stardust, right? Scoliosis, even Milwaukee brace, which looks like this, has a metal bar in it. How do you differentiate between Boston brace and Milwaukee brace? Boston brace looks like a bridal gown, so it looks somewhat like this. Milwaukee brace has this metal bar in it, so it is a metal jacket type of brace. Both of them are used in scoliosis. Yes, Dr. Jane, KK, all of you are right. It is used in scoliosis. Most commonly used is Boston brace, but the best brace is Milwaukee brace. Okay, best brace is Milwaukee brace. Most commonly used is this. So these both you can rule out. It is not Boston brace. We don't use that in fracture. Next, let's understand this. This is a Taylor's brace. Now Taylor's brace has these metal bars here which prevent from flexion. But these braces are not very effective because the metal bars are behind. Some amount of flexion is still allowed. So where is Taylor's brace used? We use Taylor's brace in osteoporotic fractures, not in normal fractures, in osteoporotic fractures. Normal fractures we can never use them because they won't give enough immobilization. Imagine a young patient with a vertebral fracture. If you don't have enough immobilization, it will collapse. So you cannot use Taylor's brace in this cases. Taylor's brace is used in osteoporotic fractures. The answer to that question was a ash brace. An ash brace prevents flexion. It prevents flexion and it keeps the spine in extension, in active extension, and this is the brace that we use in cases of compression fractures. Okay, so this is the answer. Ash brace is the answer. Lumbar corset belt is this belt which we normally see our elderly people wearing or our parents wearing. This is not very effective in immobilization. The only thing is in patients with disc pathologies, if you want to reduce intra-abdominal pressure so that disc pathology is not aggravated, you can give them a lumbar corset belt, but not very effective in any cases. Lumbar corset belt is more of a placebo effect. Okay, so the answer is ash brace. Please remember, ash brace different from Taylor-Knight's brace, different from Boston Milwaukee brace. Okay, so these were about spinal orthosis and cervical orthosis. Few I want you to remember. Can you tell me which type is this? Which brace is this? Cervical, which brace is this? So let me mark this A, B and C. If you can tell me all three of this or any of them. Stardust, Dr. Jain said this is Philadelphia. Correct. This is Philadelphia brace. It has this opening in it for intubation, so for tracheostomy. So this is a Philadelphia brace. This gives good amount of neck immobilization. Which is this? B. Shabir says C is SOMI. Correct. You're right, Shabir. This is SOMI, also called as sterno-occipitomandibular immobilizer, which is a very good kind of immobilizer for upper cervical and cervical injuries. Best type of immobilization for cervical spine. Dr. Jain, this is a collar. What collar is this? It is a soft cervical collar. B is a soft cervical collar. Yes, Shazad, you're right. A is Philadelphia collar. B is a soft cervical collar. It is again a primitive type of collar. B, this soft cervical collar is a primitive type of collar, does not give a lot of immobilization. Best one is SOMI, then is Philadelphia, and then is soft cervical collar. Okay, so these are three types of cervical collars. Now let's go into braces, and these are questions that was asked last year. I think there was a question asked on one of the brace, so please let's answer this. Identify the splint used below and the injury it is used for. Options are static cock-up splint used in radial nerve injury, or dynamic cock-up splint used in radial nerve injury, or dynamic cock-up splint used in ulnar nerve injury, or knuckle bender splint used in ulnar nerve injury. Simple question again. What is this brace and which condition is it used for? So Shabir says it's B. Stardust also believes this is B. Dr. Jain, okay, everyone is in the consensus that this is B. So my objective here was to make you remember all of these braces. Okay, so all these braces I want you to see. So look at these braces here, all of them present here. These two braces here, you can see whenever you're looking at braces, always look at what that brace is doing to the hand. Even if a question comes where you're confused as to whether it is a turnbuckle brace or it is a knuckle bender brace, please look at what the brace is doing to the hand. For example, look at these two, the first ones I've marked here. These braces are causing wrist and finger extension. They're causing wrist and finger extension. This is not possible in which type of injury? It is not possible in radial nerve injury. So this is used in radial nerve injury. And what is this brace called as? They are called as cock up splint. Two types are there. This is dynamic. This is static. Dynamic because it has these movements. So it will always cause these movements. That is why it is dynamic. You can see here wirings are there, no? So this is dynamic and static cock up splint. What is this one here? Can you tell me? Can you see what it is doing to the hand? It is making the finger, the metacarpophalangeal joint, go into flexion 90 degree, and it is causing the IP joint to go into extension. It is causing this movement. Now this movement is not possible in which injuries? Which muscle is responsible for this? Stardust says it is knuckle bender splint. So this movement is mainly by flexors, by the long flexors and also by the lumbrical. So if they are damaged, which nerve is injured? It is the ulnar nerve that is injured. So this is a brace used in ulnar nerve injury. So this way you can decode each of the braces without even going into just remembering the picture or by hearting them. Just look at what the brace is doing to the hand. Okay, yeah, lumbricals, correct. You're right, Stardust, lumbricals. So this has to be an ulnar nerve bend, and because it is flexing the knuckles, it is bending the knuckle region. MCP is going into flexion. We call it as knuckle bender splint. Knuckle bender splint. Now let's go into this one here. Here, can you see the hand is going into abduction and some amount of external rotation. So what is this used in? And what is the name of the splint? Yes, so Dr. Jain has answered it together. Aeroplane splint used in brachial plexus, right? So what happens when brachial plexus injury, mainly Erb's paralysis, is that hand goes into adduction, shoulder goes into adduction. Now to counter that adduction and all the relative movements along with that, we have to use this aeroplane splint to keep the hand in some amount of adduction and external rotation. So that will counter the adduction of Erb's paralysis. So this is mainly used in Erb's palsy. And it is because the hand looks like an aeroplane, we call this as an aeroplane splint. Now look at this. So last year, one of the years, this was a question, and I remember many students marking this as a this thing, cock-up splint. Most of them have marked this brace as a cock-up splint. What do you think this is? Dr. Jain says it is turnbuckle. Dr. Jain, can you also tell me the condition where you think this brace is used? Anyone else who think what is this? Yes, Dr. Jain is right. He's answered both of that. Turnbuckle splint used in Volkmann's ischemic contracture. So what is happening here? Can you see here how there are two rods and connecting to that is this turnbuckle mechanism. So what this does is it helps in, it gives some amount of extension at the elbow region. What happens in Volkmann's ischemic contracture? Your muscles are gone, have lost their length. They've contracted. These muscles have lost its elasticity and it has become fibrous. That is called as Volkmann's ischemic contracture, because of which you will have this clawing effect. Now, in early cases of VIC, if you just give some amount of extension to the muscle, then the clawing can be, or this deformity can be prevented, and that is what a turnbuckle splint does. It is used in mild cases of VIC where there is shortening, and it is called as turnbuckle splint. Why is it called as turnbuckle splint? Because it has that turnbuckle mechanism with which little lengthening can be done in the brace, okay, which will help in reducing the deformity. Now this is the last one that I want you all to look at. Can you tell me what this is and where is it used? Okay, Dr. Jain says is foot drop. Used for foot drop. What is it called as? Name of that splint? Yes, sir. Common peroneal nerve injury. Correct. All of you are right. So this is used in foot drop cases. We can call this as a foot drop splint or an ankle foot orthosis, AFO, because it's including the ankle and foot, or it is also called as a toe raising splint. Toe raising splint. It's 3 names it has: ankle foot orthosis, foot drop splint, and toe raising splint. So these are all the splints that I want you to remember. This is the table: cock up splint, knuckle bender splint, turnbuckle splint, aeroplane splint, and even median nerve has a splint which they might not ask you commonly, but it is thumb abduction splint or opposition splint, ankle foot orthosis, foot drop splint, common peroneal nerve palsy, like you all said. So you all were right. The answer is correct. Okay, so please note down this chart, help you with all the splints used in nerve injury. So the answer here was B. Now let's come to another question. This is from Spine. Again, a 65-year-old postmenopausal female came with persistent back pain, not responding to conservative treatment. History of lifting heavy weight 4 months back with progressively increasing pain that worsens on walking. The pain starts radiating down her legs after walking for around 100 meters distance. She, however, feels no pain on climbing up the stairs. Most probable diagnosis is again an INICET question. Options are osteoporotic vertebral compression fracture, lumbar canal stenosis, atherosclerosis, and thromboangiitis obliterans. Now, before you jump into the answer, first I want keywords. Which are the keywords that are helping you answer this? Dr. Jain has already given me the answer. That is lumbar canal stenosis. You are right. Dr. Jain, Stardust, KK, all of you are right. But tell me keywords again. You have to highlight keywords that will help you tell the answer. Which were the main keywords that gave away the diagnosis? Neurological claudication. See, I have not mentioned neurogenic claudication in the question. So what is neurogenic claudication according to you? What is the line that told you that it was neurogenic claudication? Forward, correct. Yes, doctor, you are right. No pain on climbing up, correct. Yes, all of you are right. So this is a case of neurogenic claudication seen in lumbar canal stenosis, and the clinical picture for lumbar canal stenosis will be an elderly patient. They'll have hallmarks of neurogenic claudication pain. What are these hallmarks? The most important one, which Dr. Jain and Stardust you didn't tell me, is patient is not able to walk after 100-meter distance. That is exactly what is referred to as claudication distance. When we talk about clinical scenario, we talk about claudication distance. How much can a patient walk? And that is claudication distance. Okay, some relief due to forward flexion. Yeah, correct, Stardust, you're right. So neurogenic claudication, one thing is claudication pain. Another thing is there will be posture related pain. Patient will have more pain on standing straight, but as he bends forward, the pain will reduce. This is because that canal will open up. As you bend forward, the canal will open up and it will give the cord some breathing space, and that is why this pain will reduce. And also when you're walking uphill, you realize that you're walking stooping forward, so pain will reduce. Also this positive shopping cart sign, because as you're holding a cart and going, you tend to bend forward and your pain will reduce. So that is why all of these features are seen. So what is spinal canal stenosis? It is when the spinal canal is compromised, neural compression is there, that will produce the symptoms. Mainly claudication, neurogenic claudication symptoms are seen. Lumbar canal is more commonly involved than cervical canal. And all of these will be there. On standing also patient will complain of pain. On sitting also patient will have pain because canal is still compressed. But on bending forward, that is while going uphill or while taking shopping cart, pain will be better. Okay, can you, now there are two components. One is neurogenic claudication, one is vascular claudication. Can you tell me differences between neurogenic and vascular claudication? So one of that you've told is that patient while bending forward in neurogenic claudication, there will be relief of pain. Any other things that you know of? Anything else? So what happens with the claudication distance in cases of neurogenic and in cases of vascular? In which is it variable, in which it is fixed? Radiation of pain. Okay, radiation of pain is more common. Okay, fine, can take that, but not a very clinching difference. Fixed in vascular. You're right, Dr. Jain. This claudication distance will be fixed in vascular, but it will be variable in cases of this, because posture related, because of how your movements are. That's why in cases of neurogenic claudication, your claudication distance might change. Any other things? Distal pulses, how are they in cases of both neurogenic and vascular? Anyone? Any other diagnosis? Distal pulses, anything about distal pulses? Vascular, this is correct. Yeah, Shabir, you're right. So normal neuro and non-neuro, vascular we're talking about. Okay. So, okay, you mean in neurogenic claudication, it's normal. Yeah, right. You're correct. So these are the differences that I want you to remember, that in claudication, distance is variable in neurogenic. In vascular, it is fixed. Provoking factors are walking and standing. Even standing, neurogenic claudication, there will be pain. But in vascular, it is only while walking. Both standing and sitting will relieve the pain in vascular claudication. Neurogenic claudication pain will only be relieved when you bend forward. Okay, when you're sitting, bending forward. Other activities like walking uphill, bicycling, pushing a shopping cart, all of them will relieve pain in neurogenic, will not relieve in vascular. Pulse is normal in case of neurogenic, it is affected in vascular. Back pain is one of the symptoms that are seen in neurogenic. Vascular, you might not have back pain. You'll have this pain, the aching, dull aching pain in the leg. And neurodeficits may be present in case of neurogenic, not seen in vascular. And time to relief is another important thing, that in neurogenic the relief is very slow, because cord compression relieving pain will be recovery will be very slow. It will take few minutes. But in vascular, immediately as you sit down or immediately as you stop walking, your pain will reduce. It's a quick recovery. Okay, so these are the differences between neurogenic and vascular claudication. So the answer, you're all right, is lumbar canal stenosis. Now let's go back to PMR topic again. This is lower motor neuron lesion. So in lower motor neuron lesion, they might ask you questions from EMG and NCV, which are very commonly done, electromyographic scans and nerve conduction studies or velocities mainly. So few things about EMG that I want to talk to you about. A neurologist sends a 34-year-old patient for an EMG. The EMG shows this image, as you can see here. This image is seen. What is your inference? And the options are insertional activity, Wallerian degeneration, spontaneous activity, interference pattern. I'm not sure whether most of you have studied about EMG, but if you have not studied EMG and NCV, I've taken that session in PMR and Medays. I've covered in detail about what NCV and EMG are. You can go and see that session. Okay, I'm sure you guys have no idea about this, but let me little bit tell you about EMG, which can be an INICET question. So what you do in EMG is, you place an electrode on a muscle and you take that reading into a machine. And through that you realize whether that muscle is still having neuroactivity or not. So that is basically what EMG is. So what it's in the app, Debraj. The whole NCV EMG session is in the app, and if you want, there is a free trial going on for maybe 1 or 3 days now. So you can go and look into NCV EMG and whatever other things that I've covered, you want to know detail about that, you can check that out in the free trial in the Medays app itself under physical medicine and rehabilitation session. Okay, so now coming back to EMG. So in EMG, when we put that electrode in, that time the first insertion, what activity you get, what reading you get is this. You'll get a reading like this. This is called an insertional activity. After that, for some time you will have the spontaneous activity. This is called as a spontaneous activity, which is normal again. After insertion, next activity is spontaneous activity. Then some motor movements will be seen. That is a motor unit recruitment and configuration, also called as MUAP, action potential. It is motor unit action potential, which will look like this. And sometimes because of interference pattern, you might have this kind of disturbance as well. So these are the 4 things which are normally seen. But pathological things that a neurologist is looking for are 2 things. One is positive sharp wave. This positive sharp wave and fibrillation potential. These 2 are both suggestive of Wallerian degeneration. Suggestive in EMG of Wallerian degeneration. Now if you look back here, can you see both of these? What are these? These are positive sharp waves. These are sharp waves. What sharp waves are suggestive of Wallerian degeneration? So the answer here is Wallerian degeneration. This is basically about EMG, how it is done, where implications are in peripheral nerve disorders, motor neuron disorders, myopathy, myotonia, myasthenia gravis and radiculopathy. Okay, so the answer here is EMG is Wallerian degeneration. Okay, this much is important for EMG's basis for you. Next, let's come back again to orthopedics. So here you have a patient with a road traffic accident, develops a type 3A compound tibial fracture, arrange the external fixator in terms of stability, lowest to highest. This again is an INICET recall question. Okay, this was a bouncer when it was asked that year. So your options are Ilizarov fixator, uniplanar fixator with single rod, uniplanar fixator with double rod. PMR is there. It's called physical medicine rehabilitation. There is a session. I've taken that subject, and there are, I think, 6 hours of lecture videos available. Okay. So your options here are Ilizarov, uniplanar with single rod, uniplanar with double rod, and biplanar. So what do you think is the answer here? Okay, so Stardust and Dr. Jain believe D is the answer. Single rod, double rod. Okay, okay. Anyone else has an answer? And anyone else would like to try? Okay, so this concept is again maybe not covered in most sessions or most platforms, but you have to know about order of stability of an external fixator. See, external fixators can be of different types. They are uniplanar, unilateral, bilateral uniplanar, biplanar, which is unilateral and bilateral again, or ring fixator, like I've showed you in that image, Ilizarov fixator, which is a ring circular fixator, or there are also hybrid types. But what is the stability pattern in all of them? So look at this animation. This is a simple external fixator where you put 2 pins and you put a rod. You put a rod. So this is a simple one. Now if I want to improve the stability of this fixator, what I can do is, one, I can bring the rods closer. I can bring the pin, Schanz pins, I can bring them closer. So one thing is bringing the pins closer. This is one way of improving stability. Or second thing is, I can improve the thickness of the Schanz pin. Can you see here? The Schanz pin thickness has been increased. See the Schanz pin, both the Schanz pin thickness has been increased. So next is increase thickness of Schanz pin. This again will cause increased stability. Third thing is, you can get the rod closer. You can get that frame closer to the fracture. Frame or rod closer to the fracture site. This will again give more stability. Now if you want even more stability, what you can do is, you can put 2 rods uniplanar on one side only. You can put 2 rods. So uniplanar 2 rods. Or if you want even more stability, then on both sides you can put rods. So biplanar. Okay. Now if you want even more stability, the best option is to put a circular fixator, which is also called as an Ilizarov fixator. So this is the order of stability that is important to remember. See what you can do to increase stability. The most stable is Ilizarov. Second most stable is biplanar. Third more is uniplanar with 2 rods. Other options are, you get the frame closer to the fracture site, you increase the thickness of the Schanz pin, or you bring the pins closer. Okay, all of this. So what do you think is the answer? Yes, Shahzad again has understood the answer here. It is D. Okay, what is the biggest one? It's Ilizarov. Next is biplanar. Then is uniplanar with rod. Least is uniplanar with single rod. They are asking from lowest to highest. So it has to be 2, then 3, then 4, and then 1. Okay, so this is the answer. Now let's go back to another PMR question here. This type of gait is seen in which of the following? Is it poliomyelitis, cerebral palsy, common peroneal nerve injury, gluteus maximus weakness? What is happening here is, the patient is walking holding his hand to his knee. So can you tell me what is the type of gait and which condition it's seen in? 2 questions. Dr. Jain says it's A, poliomyelitis. Anyone else would like to try? Also, which gait is this? Also, if you can tell me the name of the gait, that also will contribute to the discussion. No one knows the name of the gait? Okay, so we'll go forward with this gait that is seen is a hand to knee gait, and the concept that I want to discuss about poliomyelitis. So this hand to knee gait is seen in poliomyelitis. And why is it seen? Because in polio, okay, Dr. Jain doesn't know the name of the gait. Simple name, because the hand is in the knee, we call it hand to knee gait. The reason this is done in cases of poliomyelitis is because there is quadriceps weakness in this patient. So what will happen, as he tries to walk, his knee will buckle. Now, to prevent the knee from buckling and keeping it in a locked position, what he will do is he'll voluntarily keep his hand on the knee to prevent the knee from buckling. This is called as a hand to knee gait. You would have seen it in a lot of people. They'll hold their hand to their knee and as when they walk, because they have quadriceps weakening, and this is mainly due to poliomyelitis. Yes, Stardust, you're absolutely right. Poliomyelitis due to quadriceps weakening. Correct. So this is the hand to knee gait, and poliomyelitis is an important concept again, and I've again discussed this in a 1-hour session or a 45-minute session in the videos. If you want, you can go back and see more about poliomyelitis. Few things I'll tell you from INICET point of view is, okay, in PMR postings, you've seen that hand to knee gait. Okay, very good. So this is how you will correlate things clinically as well. So in poliomyelitis, few other MCQs that are important is, which is the most common bone that is fractured in polio? The answer is supracondylar femur fracture. Also, in polio, they'll ask you a question, is fracture healing interrupted in cases of polio? And the answer is no. Fracture healing is normal in cases of polio. No, if fracture occurs, not that fracture has to occur. In patients of polio, what happens is they have some amount of weakness in the supracondylar femur region. That is why they are prone to more fractures. Not that in polio you will have fractures, but they are prone to more fractures because of these ITB contractures, because of the muscle contractures, and because of general metaphyseal weak remodeling of the bone as well. Okay, Stardust, it doesn't mean that there is a fracture in supracondylar region. More commonly seen in supracondylar region. Okay, and also femur is also one of the most common sites of fracture in other conditions like arthrogryposis and muscular dystrophies. Okay. Now, another thing you need to know in polio are all the deformities that you will see. Main deformities are because of iliotibial band contracture. What will happen most commonly in the hip is, hip will be in flexion, abduction, external rotation. Knee will commonly be in flexion. Knee will also be in valgus, and sometimes you might see triple deformity of the knee, that is flexion, posterior subluxation, and external rotation of tibia on femur. Any other condition where you will see triple deformity of the knee? Anyone has heard this triple deformity of the knee somewhere else? You can put it in the chat box. Okay, ankle and foot you will see equinovarus, and spine and pelvis you will see lumbar scoliosis and pelvic obliquity. Yes, TB arthritis. Dr. Jain, you're right. TB knee also you will see triple deformity of the knee. Okay, so these are all the conditions seen in polio. This is all the deformities they are seen. And one thing they might ask you is, in polio, because iliotibial band contracture is seen, what is a test you will do in iliotibial band contracture? The test is Ober's test. What do you do in Ober's test? See here, you can see he's stabilizing the hip in one hand, and he's trying to abduct the hip. He's trying to abduct the hip above, and once you abduct the hip, you extend the hip as well. See, you will extend the hip like this, and after that you will leave the hand, you will leave the supporting hand, and if the leg falls down, that means ITB is not contracted. But if the leg hangs, as you see in this image, if the leg hangs like this in this position, that means that there is an IT band contracture. So it is an Ober's test that is done. This is the image that you will see, IT band contracture, iliotibial band contracture. You will see Ober's test seen in cases of poliomyelitis, because IT band contractures are more in cases of polio. Now let's come back to again orthopedics. We have a 10-year-old girl presenting with early onset puberty, café-au-lait spots, multiple fractures, minimal trauma, radiography showing polyostotic fibrous dysplasia. Which of the following gene mutation is most commonly associated with this condition? Okay, I'll give you the options: COL1A1 gene, XT1 gene, GNAS gene, and NF1 gene. See, you can either tell me the answer, or you can rule out other options by telling me these genes are mutated in which disease, because all 4 of these genes do mutation in one or the other. So Stardust tells GNAS1, Mcune-Albright. Okay, fine. Debakar goes with C as well. Okay, anyone else? Debraj and Stardust both believe it's C. Dr. Jain also believes it's C. Okay, can you also tell me, with these other gene disorders that are there, they are you seen in which diseases? This COL1A1 gene, XT1 gene, NF1 gene, they are seen in which conditions? so that we can rule them out and then establish our answer? A is seen in osteogenesis, perfect. Blue eyes, all that. Osteogenesis imperfecta. So this is seen in osteogenesis imperfecta. You're right. Okay, and then B, where is B seen? Okay, Dr. Jain says NF1 gene is seen in neurofibromatosis type 1. Agreed? Neurofibromatosis type 1. Correct. You're right. Okay, Dr. Jain, Stardust, all of you are right. Now we have to only rule out B. EXT1 gene is seen in which condition? A clue, it's an orthopedic condition. Okay, Stardust says he doesn't know the answer. Okay, so B is seen in a condition called as hereditary multiple exostosis. Okay, this is where EXT1 and EXT2 gene are getting involved. So HME, hereditary multiple exostosis, this is where you see EXT1 gene. But your answers were right. It is GNAS mutation. So what happens in GNAS mutation? So GNAS meaning a GTP protein. It is mainly a GTP protein, and not Mafuji. Mafuji is a different one. This is seen in exostosis. Okay, so now let's talk about what happens in fibrous dysplasia. So in fibrous dysplasia, GNS mutation is there, and this mutation can occur in two phases. One, this can occur in embryogenesis. If this occurs in embryogenesis, all the bones are getting involved, at least multiple bones are getting involved, and this is called as polyostotic fibrous dysplasia. It is called as polyostotic fibrous dysplasia, and there is one syndrome here which is important, which already someone has told me here. It is Mcune-Albright syndrome. It is Mcune-Albright syndrome. Now one more question I want you to answer is, in this, which is the most common bone affected? In a polyostotic femoral dysplasia, yes, Dr. Jain, Shepherd-Crook deformity is seen in fibrous dysplasia. But can you tell me, in polyostotic fibrous dysplasia, which is the most common bone affected? Proximal femur. Okay, someone's told it's proximal femur. Anyone, anything, any other answers? Or I'll give you another thing. I'll tell you that, see, but if this occurs in later stages, if it occurs later stages after embryogenesis, then you will have only a single, you will only have isolated cases of fibrous dysplasia, and this is seen in a different bone. Most common bone seen in cases of monoostotic femoral dysplasia. So tell me both of these answers. One is most common bone seen in polyostotic, one more is in mono. Okay, so Dr. Jain is telling me that in mono femur is, I agree with this answer. In most common bone in monoostotic is femur. Correct, it is femur. Can you tell me, Dr. Jain, can you tell me in polyostotic which is more common? Okay, maxilla. Correct, you're right. So maxilla is the answer I was looking for. So in polyostotic fibrous dysplasia, it is maxilla. In cases of monoostotic, it is femur. Okay. Starters, and anything wrong? Did you get this concept? Any confusion, Stardust? Just let me know. Okay, so this is the concept that fibrous dysplasia is mainly a developmental abnormality or arrest where the gene mutation, there is failure to produce normal lamellar bone. Types, no, if it is monoostotic, most common bone is femur. But if it is polyostotic, most common bone is not femur, it is maxilla. Okay, second most common is femur. Now what signs are seen in x-rays? What all signs do you see? I want two signs that needs to be told here that are seen. No problem, Stardust. This is mainly meant for revision itself. Few things you will end up forgetting a little bit here and there. That is why revision is important. So you can go back, study again. Now, Stardust, because you studied this, can you tell me quickly the X-ray signs that you know? Yes, very good, very good. You've told me Shepherd-Crook deformity, correct. One sign in fibrous dysplasia is Shepherd-Crook deformity. Any other sign that you know, Stardust, that is seen in cases of fibrous dysplasia? What is this here? Can you see here? There is a lot of enhancement. There is a lot of thickening. Ground glass appearance, yes. Any fibrous type of tumor, you will have ground glass appearance. Be it fibrous dysplasia or other fibrous tumor, ground glass appearance is seen. You're right. Ground glass appearance, Shepherd-Crook deformity. Can you tell me what this is, Stardust? Anything? Anyone? What? Ground glass. Okay, you meant ground glass. Fine. Any other sign that you know of? What do we call the coverings of any fruit? Be it an orange, the peel of the orange, what are they called as? There's a name that we give. No one knows. Okay, so it is called as rind. So these coverings of these fruits are called as rind, and they are thickened. Similarly, even this bone is thickened. Yes, Dr. Jain is right. It is a rind sign. One is the rind sign, and second one, as you all have told, is the Shepherd-Crook deformity. So these are the two signs that we see. And what do we see in histology? What do we see in histology in case of fibrous dysplasia? What is this man trying to read so difficultly? What is this script that is so difficult to read usually? What appearance is seen in cases of fibrous dysplasia histology? Chinese. Just Chinese? Because the man is Chinese here? Yes, you are right, Dr. Jain. It is the Chinese letter pattern. So you will see a Chinese letter pattern in cases of fibrous dysplasia, and that is the histopathological finding that you need to know about. And this is the Mcune-Albright syndrome. So what you see, what are the triad of Mcune-Albright syndrome? Can you tell me three important things in Mcune-Albright syndrome? One, we agree, is polyostotic fibrous dysplasia. That we've already established. That is one. What are the other two things that you see in the image? Yes, precocious puberty is one of them. Yes, polyostotic fibrous dysplasia, correct, KK, you're right. Two things we've got. What is the third thing? One more thing that you see. Yes, right. It is Café-Aulard spots. It is Café-Aulard spots. Okay. So this is the one gene mutation called as Mcune-Albright syndrome. The triad, like you saw in the question also, was precocious puberty, polyostotic fibrous dysplasia, and Café-Aulard spots. Now, Café-Aulard spots for you is important in two conditions. It is seen in two conditions. One we know is fibrous dysplasia. What is the other condition where you see Café-Aulard spots? Anyone who's studied dermatology perfectly and can tell me the answer here? See, one is Café-Aulard spots. Where else will you see Café-Aulard spots? Sorry, one is fibrous dysplasia. Where else will you see this? Any other condition where Café-Aulard spots are seen? Yes, Stardust, you were right. One was precocious puberty. Dr. Jain is saying NF. Anyone else has an answer? Okay, you're right, Dr. Jain. Two places where we do see Café-Aulard spots are in neurofibromatosis and in fibrous dysplasia, but there is a difference between the Café-Aulard spot. So look at this. Look at the Café-Aulard spot that you see in look at the Café-Aulard spots that you see in cases of neurofibromatosis. This is the one. Here, what you see is the border is very smooth. There is a smooth border, and some person who saw this border, preferably a person from the US, saw this border and compared it with the border of California, the coast of California, which is also very smooth. So he called this Café-Aulard spots as coast of California. He called it as coast of California, and the spots that are seen in fibrous dysplasia are very rough. They have these irregular margins, and that is why it is being equated to the coast of Maine. which also is somewhat like this. So these are maps of California and Maine. So you can see the difference between the two coasts here. This is irregular. So that is how you will differentiate between two of these cafe spots. Can be a question asked from dermatology and ortho side. So these are the two important ones that you need to know about. Okay. Now let's again come back to PMR. An important chapter in PMR is spinal injury. Few more questions, and after that we'll be ending the session. Is it okay? I can continue, right? Anyone else who feels that I need to stop right now? Because we might have another 5 to 6 questions, that's all. And even there is a last one session where I'll try to talk about exam leaks, important questions. So can I continue or should I stop the session? Are you all tired? Okay, starter says we can continue. If anyone feels like I should stop, please let me know. Okay, so spinal injury we'll talk about. So look at this spinal injury. One question is here. A 45-year-old man had a fall from height and suffered a dorsal vertebral fracture with spinal cord injury. The patient is presently in spinal shock. Which would be the first sign which would indicate recovery from spinal shock? And the option, this is a multiple choice correct answer type of question. So one is contraction of anal sphincter in response to stimulation of trigone of bladder with either a squeeze on the glans penis. Second option is cremasteric reflex positive. Third option is contraction of the anal sphincter in response to stimulation of trigone of bladder with pull of urethral catheter. And fourth one is knee jerk reflex becomes positive. 4 options here. You can have multiple correct answers. The question here is that patient is in spinal shock. Now in spinal shock, all reflexes, motor, sensory will be absent. Now when will we know that patient is recovered from spinal shock? Which is that one thing that we look at when we are checking for recovery from spinal shock, which is the first thing that they are asking you, first sign that is seen. A and B. Starter says it's A and B. Even if you don't know the options or you know which reflex it is, also if you can tell me, it is a good thing. Okay, so Dr. Jain believes it's cremasteric reflex. And anyone else with a different answer? So the question is basically this: which is the reflex which first comes back when your spinal shock is recovered? A, B, C. So Sarda says it's A, B and C. You know, Dr. Jain has changed his answer to C. Let me tell you, I think this concept, there is a little bit of confusion. So let me tell you this. See what happens in spinal cord injuries. So when a patient comes to you with a spinal cord injury, when you check his motor, sensory and reflexes, they'll all be absent below the level of the lesion. If he has a D12 fracture, maybe the lesion below that area, both motor, sensory, reflexes will be absent because the patient is in spinal shock. This spinal shock will be there for 24 to 48 hours. And after 48 hours, the spinal shock will recover, and at this time, you can check for his motor and sensory response. If it is an incomplete cord injury, his motor or sensory, some amount would have come back. And this is where you can check for prognosis. How much damage has happened, now you can check once spinal recovery has happened. But the question is, how do we know that spinal shock has recovered? Which is that one reflex that we check for to know spinal shock has recovered? And the answer is bulbocavernous reflex. It is bulbocavernous reflex. So what you do in bulbocavernous reflex is either in females you tap on their mons pubis, you tap on the female's mons pubis, or in males you tug their glans penis, or in most patients, most spinal patients have catheter. So if they have a catheter, you will have to pull the catheter. Okay, when you do all three of these things, because of this root action going into the anal sphincter, it will result in contraction of the anal sphincter. Okay, it will result in contraction of anal sphincter. That means that bulbocavernous reflex has come back and also spinal shock has recovered. Spinal shock has recovered. So this is what is bulbocavernous reflex. Look at this: contraction of anal sphincter in response to stimulation of either the trigone of the bladder with either you squeeze the penis, or you tap on the mons pubis, or if the patient has a catheter, you tuck the catheter. When you do these three things, you will notice that if there is contraction of anal sphincter, that means spinal shock has recovered, and the root value of this reflex is S2, S3, S4. Now let me go back to the question. Can you tell me now what is the answer? Look at the options here. Yes, Dr. Jain, you're right. It is A and C. Both of them are the answer. Here, squeezing on the glans penis. Here, pull of the urethral catheter. So this is the answer. Not cremastic reflex. That has nothing to do with your spinal shock recovery. It is only these two things that will first help you get it. The second will be anal wink reflex, but the first one is bulbocavernous reflex, which is very important in patients of spinal cord injuries. Okay, so that is bulbocavernous reflex. So these both, A and C, is the answer. Now let's come to a very important question. I've seen many students struggling with the difference between quadrata equina syndrome and conus medullaris syndrome. This was a question that was put up in our WhatsApp group as well. A 54-year-old man comes to the emergency department with sharp stabbing backache that radiates to the back of the legs. He has fallen frequently during the last 2 weeks. He noticed increasing difficulty initiating urination and pain in the saddle region with abnormal sensation. Physical examination shows severe bilateral lower extremity, proximal and distal muscle weakness, which is more pronounced on the right side. Knee and ankle reflexes are absent bilaterally. Anal sphincter tone is diminished. Sensations are diminished asymmetrically. What is the location of the lesion responsible for this patient's presentation? Your options are conus medullaris syndrome, quadrata equina syndrome, cervical myelopathy, and dorsal vertebral fracture. Okay, so two things. One, again, keywords. Tell me, Dr. Jain says it's quadrata equina syndrome. Dr. Jain, what are your keywords? Why do you think it is quadrata equina syndrome? What helped you understand that it might be a quadrata equina level lesion? Knee and ankle both are absent. Okay, what does that mean? So knee, ankle both are absent. So what are the nerve roots for knee reflex? What is the root value for knee? What is the root value for ankle? If you know, you can answer them. AY, what do you mean by that? I didn't understand your thing. Asymmetrical. Okay, got it. Right. Because it is asymmetrical, also you think it is quadrata equina syndrome. Right, Dr. Jain, you're right. You're absolutely right about this. So you understood the concept of quadrata equina and conus medullaris. Anyone else wants to try as to why? Any other things that you remember? Someone thinks it's conus medullaris? Yes, Stardust says ankle is S1. Right. What is knee then? Knee is which one? L3. Okay, Dr. Jain, L3 and L4, but L4 primarily. L3 and L4, but L4 primarily in knee jerk. Okay, so you're right. The answer is quadrata equina syndrome, and the reason, the keywords I'll highlight here. The first keyword is there is pain and abnormal sensation in the saddle region. This is one of the keywords. Second keyword is there is muscle weakness that is more pronounced on the right side. That means asymmetrical muscle weakness. Third thing is knee and ankle reflexes are absent. Fourth thing is sensations are diminished asymmetrically, and also anal sphincter is diminished. All of these are keywords that will tell you the diagnosis, and I'll tell you how. So let's understand conus medullaris and quadrata equina clearly. I think Dr. Jain has understood the concept. Let me tell it to the others as well, that what is quadrata equina and what is conus medullaris and why are these syndromes different. Look at this. This is a very simple image. Here you can see that the cord ends at somewhere at L1 or L2. The cord will end at L1, L2, but the roots are still given up till S1, S2 and other regions. So even though the cord ends at S1, S2, L1, L2, these nerve roots come out of the cord and they will then go and give into L3, L4, L5, S1 and the rest of the region. So this tip of the cord, mainly at the region of L1, L2, this is called as conus medullaris because it looks like a cone. It is called as conus medullaris, and these nerve roots which are given out, they are called as quadrata equina because quadrata equina means horse's tail, and these nerve roots, because there are so many numbers and they lie like that, they look like a horse's tail. So we call them as quadrata equina. Any damage to conus medullaris results in conus medullaris syndrome. Any damage to quadrata equina results in quadrata equina syndrome. Now conus medullaris is the cord region. So any damage here is an upper motor neuron lesion. Any damage in quadrata equina is nerve root damage. It is not damage to the cord. So it is a lower motor neuron lesion. Okay. Now if they ask you what roots are damaged in case of conus medullaris syndrome, look at what is present in the tip. In the tip only a sacrococcygeal level is present. So there will be damage only to sacrum and coccyx roots. Okay, to those areas, to those dermatomes, there will be damage. But if quadra equina is damaged, there will be damage from L2 to sacral, all nerve roots. That is why in cases of conus medullaris, only the S1 nerve root is sacral nerve root is damaged, so ankle reflex is lost. But in quadra equina syndrome, knee jerk, which is L4, and ankle, which has S sacral roots, both are damaged. Okay, did you understand? This is difference between conus medullaris and quadra equina. Please remember this table, and very simple. That diagram is only going to tell you. Let's look at each of them. See, vertebral level. Conus medullaris ends at L1, L2. Quadra equina starts from L2 all the way till sacrum. Spinal level, conus medullaris only has sacral cord roots. But in quadra equina, not roots, sacral cord segments. But in quadra equina, they have roots. They are lumbosacral nerve roots, both lumbar and sacral. Presentation, because conus medullaris is the small structure, there will be sudden and bilateral presentation. Both the limbs will have motor and sensory equally, because it's a small thing. Compression on that area will result in bilateral, sudden, and it will be high grade. But quadra equina, because there are so many roots, some roots will get damaged, some will get damaged later on. Because of that, you will have unilateral asymmetrical presentation. But because nerve roots are involved, radiculopathy is more in cases of quadra equina, less in cases of conus medullaris. And reflexes, I've already told you, ankle jerk is affected in conus, quadra equina, both ankle and knee jerk, and plantar is absent here because it is element type. Plantar is extensor in conus medullaris because it is UMN type of lesion. And last one, which I don't think you mentioned, is sensory. Saddle anesthesia is seen in quadra equina. Perianal anesthesia is seen in case of conus medullaris. So this is the difference between conus medullaris and quadra equina. I hope this is understood. Everyone has got what conus medullaris is, what quadra equina is. Just remember this diagram. This much is enough for you to remember the whole thing about all the differences of quadra equina and conus medullaris syndrome. Okay. I hope there are no doubts here. So the answer here was quadra equina syndrome. Why? One thing, because knee and ankle, but that's not the only reason. Other keywords are asymmetrical. Can you read? There is asymmetrical sensation, asymmetrical motor involvement. Where is it seen asymmetrical? In roots. When there are roots, few roots are damaged, you will have asymmetric presentation. Also, another thing is saddle anesthesia is also mentioned in the question. Even that is one of the reasons why it has happened. Okay. Now that we've finished all of this, we've completely covered PMR as well. Now let's go on to 3 or 4 exam leak questions, which I believe are topics that are important for your exams, and questions from this topic can come. Okay, quickly we'll solve them. We'll try to finish this session as soon as possible. First question is a 6-year-old child who's fallen from an outstretched hand, has lateral elbow pain and swelling. On examination, 3-point bony relationship is altered. X-ray is done. This is the X-ray. Which complication will you not expect in this type of injuries? Is it cubitus varus, tardial nerve palsy, loss of elbow range of motion, and physial arrest? I'll zoom into the X-ray if you want. So look at this X-ray. First tell me the diagnosis. Then we'll go on to what complications of the diagnosis. Starters is directly gone to the answer. He believes it is A. Starters, what do you think? And Dr. Jain also says it's A. What is the diagnosis, Starters? What is the diagnosis, Dr. Jain? What do you see in this X-ray? No one knows the diagnosis? How did you answer the question without diagnosis? See, is this supracondylar humerus fracture? We'll try to rule out. Is a supracondylar humerus? Okay, Dr. Jain says it's lateral condyle fracture. You're right, Dr. Jain. See here, there is a small fracture here. I hope this is clear in your screens as well. Looks like slipped radius. No, it's not a slipped radius. Starters. The thing is, radius head is not ossified because it is a child, no? Radial head is not ossified, so it looks as if the head is down, but actually the head is here. It is getting ossified. Okay, this is not a slipped radius. This is a case of lateral condyle humerus fracture. I'll show you again this X-ray. I'll try to erase my marking. See here. Can you see here this fracture here? This is a lateral condyle humerus fracture. Dr. Jain, you are absolutely right. Why can't it be? It's just based on the question. Why can't it be supracondylar humerus fracture? Let's not focus on the X-ray. Why, based on just the question, can we rule out supracondylar humerus fracture completely? Okay, yeah. The X-ray, I think, yeah, in children's X-ray, it is always a little tricky. But I think if you correlate two things, then maybe it will help you. If you correlate the fact that they're talking about 3-point bony relationship, then you know that nothing to do with radius. They're talking about elbow injuries. And mainly 3-point bony relationship is usually included when it's either a lateral epicondyle or a medial epicondyle or a supracondylar humerus fracture. When that is there, only then they'll talk about 3-point bony relationship. Yeah, Dr. Jain is right. 3-point is intact. So 3-point is intact, meaning it cannot be supracondylar humerus fracture. Correct. So this is a case of lateral condylar humerus fracture. Now in lateral condylar humerus fracture, which is complication is not there. Stardust and Dr. Jain believe it's cubitus varus. Anyone else? Shabir, Sakshi, anyone else? Any other different answers you have? Okay. I'll talk about cubitus valgus will be seen. You're absolutely right, Stardust. So in cases of lateral condyle fracture, the clinical scenario will be a pediatric age group, commonly 6-year-old child. There will be a fallen and outstretched injury, lateral elbow pain and swelling, and 3-point bony relationship will be altered. So if you want to know about 3-point bony relationship, just look at this X-ray here, or look at the animation here. In the animation is a supracondylar humerus fracture. Here, can you see how the 3-point bony relationship is still maintained? So it's only in supracondylar humerus fracture that we have a maintained 3-point bone relationship. 3 points being olecranon, medial epicondyle, and lateral epicondyle. But if there is a medial epicondyle fracture, lateral epicondyle fracture, olecranon fracture, intercondylar fracture, or elbow dislocation, you will have 3-point bony relationship that is altered. So in our case, it cannot be supracondylar humerus fracture. The diagnosis is lateral condyle humerus fracture. Now in lateral epicondyle humerus fracture, you will have some complications like loss of elbow range of motion, non-union, cubitus valgus, not varus. Stardust is absolutely right. Fishtail deformity, tardy ulnar nerve palsy, another very important complication to remember, and physeal arrest. All these 6 things are seen, and I'll tell you why they occur. First thing is non-union. You know that there is a kind of muscle attachment towards lateral epicondyle, and because of this muscle attachment, if there is a fracture, there is a continuous pull of this muscle attachment preventing there to be a union or malunion of lateral condyle humerus fracture, and that is why non-union chances are very high. That is one complication. Second complication is, look here, look at this animation carefully. There are 2 physeal plates in the distal humerus. In lateral condyle humerus fracture, one physeal plate will get damaged. This will result in physeal arrest. So one complication is physeal arrest. Now as physeal arrest happens, one side there will be no growth, but other side of the distal humerus growth will be there. That is, here growth will continue, here growth will not happen. So as the bone starts to mature, you will notice that it goes into what? There will be skeletal maturity resulting in valgus. So as one side is not there, one more side is growing, it will start growing more laterally, resulting in cubitus valgus. So physeal arrest, cubitus valgus, non-union. And what about when this happens? There will be slight stretching of the ulnar nerve as well, gradual ulnar nerve stretching. And because it is gradual, because it is slow, we call it as tardy ulnar nerve palsy. Okay, so these are the complications that you see. Cubitus valgus is one of them, not cubitus varus, and most of the time it is asymptomatic. If it is symptomatic and very severe, you can do a Milch corrective osteotomy. That is a treatment that is followed in cubitus valgus. And then there is tardy ulnar nerve palsy. Reason we call it tardy is because it is very slow. Because it is very slow type of ulnar nerve palsy, maybe it occurs within 2 or 3 years of you developing cubitus valgus. That is why we call it as tardy ulnar nerve palsy, and usually it will be a high type of ulnar nerve palsy. Okay, that is one thing. Fishtail deformity is also seen because this lateral trochlear ossification is lost. The growth will be somewhat like a fishtail. So you will have a fishtail deformity, and also lateral condylar spur formation is seen because this area will become more prominent. You will have a lateral condylar spur formation. Sorry, this area will become more prominent. This area will form a spur. Okay, now if they ask you which is the most common complication, it is lateral condyle spur formation, not non-union. It is lateral condyle spur formation. Okay, So this was, no, that is a different kind of fistular deformity. I agree. In even distal humerus fracture, you have a fistular deformity. This is also another fistular deformity. So in both you see fistular deformity, little different there, Dr. Jain. In both are there. Even in distal humerus fracture, because of the ossification damage, you will have fistular deformity. Even here it is seen. Okay. Now let's come into another question here. Quickly, a 35-year-old male presents with left hip pain that has been worsening over past few weeks. He has a history of long-term steroid use for management of autoimmune disorder. On examination, there is limited range of motion in the left hip joint with pain on internal rotation and abduction. Radiographs are done. This is the radiograph. I will show you. So look at the radiograph here. Options are primary osteoarthritis, tuberculosis of hip, SCFE and avascular necrosis of hip. What do you think is the answer? Dr. Jain thinks it's avascular necrosis of hip. Stardust also believes it's avascular necrosis of hip. Okay, I won't stretch too much here. The one thing I always tell students is whenever other people think of steroids, they'll think of muscle, body muscle or Arnold Schwarzenegger. But if a NEET PG student hears steroid and mainly an orthopedic question, always think of avascular necrosis. Always think of avascular necrosis. Okay, so clinical scenario in a case of avascular necrosis is a young individual, male more than female, 50% will be bilateral. Steroid use will always be given, or most of the time is given in the options. Painful limp will be there, antalgic gait, groin, hip, knee pain, referred pain may be there. Range of motion, specifically they'll tell you that there is reduced internal rotation or also sometimes abduction, but main is internal rotation. Okay, and then sometimes they might give something called as a sectoral sign, which is positive. Let's not go into the detail of what is it, but these are all the features specifically to avascular necrosis. And one thing in the x-ray that I'm not sure if you have seen or picked up is, look at this x-ray here. Can you see that there is a moon shaped crack in the bone? This is called as a crescent sign. This is also a feature of avian. This is also a feature of avian called as crescent sign. Looks like a moon. That's why it's called as a crescent sign. Now let's go into another question. This is about rotator cuff muscles. Which muscle is being tested in this image here? Is it supraspinatus, subscapularis, teres minor or infraspinatus? Also, if you can tell me which test it is, it will be an icing on the cake. Anyone? Which test is this and which muscle is being tested? Stardust believes it's teres minor. Dr. Jain says it's lift-off test. Okay, where is lift-off test done, Dr. Jain? Which muscle are we testing for in lift-off? Subscapularis, absolutely right. So Dr. Jain is right here. We are talking about subscapularis, and the test that is done is called as lift-off test. And another name of this test is a Gerber's test. Okay, here what you do is you ask the patient to keep his hand behind and you ask him to lift it upwards. So he's keeping his hand like this. You ask him to lift it upwards, and you're giving some kind of resistance. If he is not able to do is, if there is weakness, that is suggestive of a subscapularis injury. And these are all the tests that you need to know. I've already shown you this table. For subscapularis, we have 3 tests: belly press, or also called as Napoleon sign, lift-off test, and bear hug test. For supraspinatus, we have Job's empty can and full can test. For infraspinatus and teres minor, Stardust, we don't do belly press or lift off. We do Patty's or Hornblower sign. And look at these tests. I'll show you all of them. This is a belly press or a Napoleon sign test. Here what you do is you try to hold your belly. Like this. You try to apply pressure and hold the belly tightly. And the examiner is trying to remove the hand off. He's trying to remove the hand off. And if he is able to remove the hand and you're not able to hold your belly tightly, that is suggestive of a subscapularis weakness. And this is also called as Napoleon sign test because Napoleon had this position usually. So that is why we call it as Napoleon sign test done in subscapularis. Next test is bear hug test. Similar, you keep your hand like this and the examiner is trying to remove it off. If he is not able to do it, that means your subscapularis is strong. This is a bear hug test. Those three were for subscapularis. Now to learn about supraspinatus. In supraspinatus, you either keep hand like this. That is, you're either holding a beverage upwards, so full can test, or you're emptying the can, that is empty can test. So you keep your hand like this or like this, and you try to lift your hand up, and the examiner tries to put resistance downwards. If he is able to resist your upward movement, then it is called as, this is called as empty can. You're right, Dr. Jain. This is empty can. This is full can. Empty can is better than full can test. Empty can test is done for supraspinatus. So this is an empty can and full can test done for supraspinatus. Next is horn blower sign. Horn blower sign, you ask the patient to hold his hand like this, as if he is blowing a trumpet or a horn. If you ask him to keep both his hands like this, as if he is blowing a horn, if he is not able to keep one hand, that is because the teres minor or even infraspinatus is weak in this patient. Teres minor and also infraspinatus. You can't differentiate between both of them. But Patty's manure or horn blower, where you ask the patient to keep hand like this, if he is not able to keep this hand, that means either teres minor or infraspinatus is weak. Okay, this is the Patty's or horn blowers test. Now coming to, I think this is the last question of this session. A 69-year-old female operated for insufficiency fracture of hip 5 days back. DEXA scores are minus 3.3. Her orthopedician started her on drug which has direct anabolic effect on bone to increase bone mass. Which drug was given? Was it bisphosphonates? Was it continuous infusion of parathyroid hormone injections? Was it intermittent parathyroid injections? Or was it selective estrogen receptor modulators? Can you quickly tell me this? This is again from osteoporosis, which is a very commonly asked topic for your INICET exams. What do you think is the answer here, Dr. Jain? Stardust? Or anyone else who's listening? Stardust says it's D. See, I want you all to focus on this. Direct anabolic effect on bone to increase bone mass. Which is the one drug that increases bone mass? No Stardust. SCRM is not the answer. SCRM acts on osteoclastic activity. It reduces resorption of the bone. It does not increase bone mass. There is only one drug that increases bone mass. Bisphosphonates, again, see, bisphosphonates is also acting on reducing osteoclastic activity. If you go back and look at how bisphosphonates act, they act by selectively inhibiting the osteoclastic activity. So it cannot be that. So yeah, answer is parathyroid hormone, but I want you to differentiate between B and C. Is it continuous infusion of parathyroid hormone or is it intermittent parathyroid hormone injections? Yes, Stardust says it's C. Correct, Dr. Jain, it is teriparatide. You're right. This recombinant PTH injection that I'm talking about in option B and C is teriparatide. But extension of this question is teriparatide given continuously or is it an intermittent parathyroid injection? What type of infusion is it in teriparatide? Yes, you're right, Dr. Jain and Stardust, both of you are right. So this is a chart for osteoporosis. So there are things that increase bone formation. Mainly it is teriparatide. Okay. So how does teriparatide act? Teriparatide acts, see, if you give parathyroid hormone continuously to osteoblast, what will happen? Parathyroid hormone directly on osteoblast will cause osteoclast coupling, and it will actually cause bone resorption. But if we give pulsatile doses of recombinant parathyroid hormone, this will act on osteoblast differently. It will cause the osteoblast to form new bones. It will ask it to form new bones, and this recombinant PTH, as Dr. Jain said, is teriparatide. Very good, Dr. Jain, it is teriparatide. So this is the thing that I wanted to talk about, a very important concept, teriparatide. Please learn about this. It is a bone forming drug. It is a drug of choice when bisphosphonate resistant osteoporosis is there. Acts on osteoblasts, given in small pulsatile doses. Usually we give one daily subcutaneous injection, and long term we give till 2 years. That is a therapy that we advise. So the answer is intermittent PTH dosages, injections. Okay, so this was about all the important concepts of INICET from orthopedics and PMR point of view. If you have any more doubts, want more questions, or want to be part of the group, I have a WhatsApp group where I regularly put up orthopedic questions, mainly INICET and niche PD based questions. So you can join this group, or if you want to get in touch with me, I have my Instagram handle is bonesmith, so you can get in touch with me there as well. So I hope this session, I know it's been long, but I hope it's been useful for all of you listening, recording or live session. I thank all of you for cooperating, giving me answers, and keeping this session more engaging and discussion based. Thank you, Dr. Jain. Thank you, Stardust. Thank you everyone that has tuned into the session. I hope this was useful. If you want more extension of these theories and these concepts, you can always go into the app Manipal Medes, where we've talked about orthopedics and physical medicine and rehabilitation. And this is the only app in which we've talked about physical medicine and rehabilitation as a subject. No other platform has covered physical medicine and rehabilitation. So if you want to know more about it, go back to the app, see the trial version. If you like it, you can subscribe to it. Thank you everyone.